Unmuted. So welcome everyone. This is our second event this year, Patient Experience, Everything MRI Forum. We have another one coming at the end, but we'll talk to you about that. So we're gonna do a little bit of housekeeping before we start. So first of all, I would like to thank our speakers. We have Selena Glenn, we have Jonathan, Sigrid, Ruth Evans, and we have Darren Hudson. Darren is not here at the moment, but he's going to be here for the roundtable discussion, of course. And as you are aware, if you saw any of our events in the past, or if you're seeing this event for the first time, just be aware that the lectures they are providing us are recorded, just to make sure there's no internet problems, there's no issues, and we miss one or two presentations. So we have a nice recording going on. But they will be on during the whole event. So if you have any questions, please drop it on the Q&A box at the bottom. You'll be able to see it on the bottom of your screen, Q&A box. Just use it as much as you want. We'll either answer your questions live or save them for the roundtable discussion. So the way the event goes is we have the recordings, we have the lectures, and then we do a roundtable discussion with all of our guests. And we are going to use your questions. So if you have any questions, just pop them in there. We have around 200 people live already. I want to speak a little bit about our sponsors. So we have two sponsors that normally help us do these events. It's Reality, a VR company that helps MRI technicians to develop their skills in safety and scanning as well. And we have Pearl Technologies with their amazing pads for patient positioning and, of course, improving patient experience overall. And, of course, we have our major support, which is PDC Facilities. I will drop the link for their website on the comments so you can see it. Please go check it. They have amazing entertainment systems. They are some of the pioneers of patient experience in MRI. So I don't have enough words for them. They are really great, but we can show more about them during the event. So as I said, the structure is the lectures. Then we have the roundtable discussion with all the questions. I don't think I have much more to say at this point. We'll kick off the event. Julian will take over from now. I just want to say one last thing, which is Everything MRI is all about community. And I'm really, really thankful that all of you took this time to be here today with us, the speakers as well. And patient experience is something that is very, very dear to me and Julian. So we care a lot about our patients. We care a lot about radiographers. And that's the main reason why we're doing these events, the podcast, the YouTube channel, everything that we do. It's for you guys and to make sure that we share what we go through as well, because we learn with you. So thank you so much once again, and I hope you enjoy this event. Julian, do you want to take off from here so we can hear from you as well, please?
Yeah, sure. Can you hear me first? Yeah, all good? Sounds all good? Okay, thank you so much, Sam, for introducing the event first. Let me just echo what you said about the fact that it's nice to see so many people from different parts of the world, as usual, as it happened before, but united by the same passion, which is obviously MRI. For those that have been following us for a while, especially different social media platforms, YouTube, for example, you might be aware that we usually kind of like keep the discussion very broad, but specifically we talk about image optimization, improving the workflow. We talk about AI implementation, MRI safety. But today is all about the patient. Today, we want to focus on the patient experience and how to improve the overall patient journey. So you can imagine there is quite a lot to discuss. So as soon as we start the beta, so allow me to introduce the very first speaker of the day. And I'm very glad to have here with us Jonathan Hughes. Jonathan is a senior lecturer in medical imaging at Chartered University in New South Wales, Australia. And he brings a wealth of expertise in areas like major trauma imaging, neurointerventional radiology, and of course, MRI. However, he's also deeply involved in research, and he has this very specific interest about patient experience, but he's also very interested about different things like the role of social media in healthcare. In addition to his teachings, Jonathan serves as an associate editor to the Journal of Medical Imaging and Radiation Sciences, and he's a fellow of the Higher Education Academy in the United Kingdom. If this doesn't sound enough, he's also one of the chair at the Australian Society of Medical Imaging and Radiation Therapy. So Jonathan will start off our discussion with a presentation which I believe immediately shed some light about the complexities that the patient tend to experience across their MRI journey. So with a presentation titled Being Distressed in MRI, the Patient Perspective, the first speaker of the day, ladies and gentlemen, Jonathan Hughes.
Hi, greetings from Australia. My name is Jonathan Hewis. I'm a senior lecturer in medical imaging at Charles Sturt University, and I'm going to share some of my research that explores adults who have experienced distress during their MRI. I would first start to acknowledge that I am joining you today from Biripi land, and the Biripi people are the traditional First Nation custodians of the land, skies and waterways, which I join you from today, although it's dark here whilst you're watching this presentation. Here's a selection of photographs from my backyard in Port Macquarie. I hope I don't make you too jealous, and this is not a recruitment campaign. To provide some brief background, anxiety and distress are still common within the MRI environment, as we'll be aware as practitioners. More recent research has found that a large percentage of patients do experience perhaps anxiety in this space. Claustrophobia has reduced for patients over time, partly to do with changes to the environment, but also approaches we may be adopting as practitioners. However, even with upright and open MRI scanners, experience of distress is not fully eliminated, and for some patients that it may still experience panic and terror. Sedation and general anaesthesia are still routinely used, and they have obviously potential complications with them, and not ideal that obviously we have to sedate patients to come through for their examinations. There's also a move now to more hybrid uses of MRI, particularly noting obviously radiation therapy and the use of MRI for planning, which brings additional challenges and considerations. Also, the fact that we are now seeing growth in the use of remote operator scanning, and this obviously has caused some interesting dialogue and consideration of the patient experience. When we look at research of patient experience within MRI, it's often been through a positivistic lens, and there is a bias certainly towards quantitative methodologies and also studying individuals that experience claustrophobia. There has also been quite a bit of research that perhaps explores the practitioner perspective rather than that of the patient. There is a growth of research that explores patient experience in MRI, but there is a limited array of first-person perspective research. As people, if you think, I guess we're diverse, and our experiences are very individual to us. What we would perhaps call in qualitative, it's intersubjective. Distress in MRI is a complex and multifaceted and very personal experience, so third-person perspectives can't really understand the subjective nature of the patient perspective. Perhaps we could say that we have lacked a deep understanding into the subjective and diverse nature of this phenomenon in the past. So I've been researching patient experience for some time, with a particular focus on MRI amongst some of my other research passions. And similarly, these are my prior publications currently out, although I do have other research in this space which is currently under peer review. What I'm showing today is actually my MRI research from my PhD, where the principal aim of this inquiry is to look at the lived experience of adults who have experienced distress during their clinical MRI examination, looking at the meaning of that distress, and also to give a voice to the participants and their collective experience. This is research that's been conducted here in New South Wales in Australia. I've used the term distress to demedicalise that term. We look at the Oxford Dictionary. Distress is a state of extreme anxiety, sadness, and suffering of pain that may require urgent help. I thought that was quite important to sort of remove the focus on perhaps looking at claustrophobia. This is a screenshot from the pilot episode of The Sopranos. This is Tony Soprano from the pilot episode. He was having a panic attack at a barbecue and is subsequently referred for an MRI. And he's very anxious before he goes, and he's convinced he has a brain tumour. And then the instructions he receives over the intercom, they are posted on the screen there as a quote. We are popularised in mythology from things like movies and sitcoms and things all the time. The underpinning methodology for my PhD is hermeneutic phenomenology, which is a qualitative research process which is situated within a constructivist and interpretivist paradigm. It all sounds very fancy, which is based on the writings of Van Manen and the philosophy of Heidegger. Hermeneutics is a way of looking at textual analysis. Textual in this particular sense because the data is gathered from people with lived experience of that specific phenomenon, so distress in MRI, through qualitative interviews, and then that's transcribed, so therefore the data source is text. It's very complex and philosophical. This I haven't got time to go into the methodology. I'm happy to maybe answer questions offline if somebody has interest in that particular space. It's a non-linear kind of process, and these three interconnecting circles, I guess, represent some of those processes of data gathering, analysis, and the writing, which occur continually during the research process. So hermeneutic phenomenology begins and finishes with lived experience. The participants bring their own lived experience of the phenomenon. 8 participants were recruited from regional and rural New South Wales, and they'd had distress within the last 6 months prior to their qualitative interviews. The first interviews varied in length from 70 minutes to 2 hours, with the longest transcript being over 20,000 words. So that gives you some idea of the depth. The researcher also brings their own lived experience, and as the research instrument, it's quite important for me as a researcher to reflect, and reflexivity and journaling was a part of the study. The preliminary findings were then taken back to 4 of those participants, where key themes were shared, and there were some member checking interviews. The final research results are then obviously disseminated, and so for example you as the audience, the lived experience component is a bit like looking at a piece of art, that you bring your own interpretation to these as a practitioner. The idea is that this study provides a vicarious first-person experience of distress of patients that experience distress in MRI, and hopefully this increases your understanding, empathy and compassion of this phenomenon. I will now share some key findings with you from the study. Just to note that there are some direct quotes actually from participants, and the names that are displayed are pseudonyms which are actually chosen by the participants. The pre-MRI period of time is a period of high distress, and as Bob, who is one of the participants, notes, that the individuals have a backstory, and this backstory is the context to which they experience their MRI. A shared experience across all the participants was that of their lived body. In phenomenology, this is the intertwining of the body and mind, because we interact literally with our body in the world. So how we interact, perceive and understand the world is through our body. All of the participants describe a body in suffering, so a body that impacted by either symptoms or an illness. Several of the participants actually had long-standing progressive disease. So for example, Max has MS. Other participants actually had very long-standing symptoms which were progressing, getting worse, but no diagnosis, leaving them sort of in limbo. And for them, the MRI was quite late stage in their imaging, and was, I guess, something of hope, hoping that they might be able to find some answers for the disease kind of process. The participants were quite focused often on these negative and abnormal bodily sensations they might have, such as pain, for example, but also things that might happen during the MRI too, to include things like claustrophobia, but also more unique and more diverse experiences. For example, Julie is concerned that she may have a seizure in this space. So not only expressing, I guess, anxiety and fragility about their own lived body, but also the individuals had anxiety about the procedure, but more importantly, perhaps the results in this particular space. Their concerns and anxiety about the procedure often were exacerbated by limited or poor information provided by the referrer, but also sometimes by the provider, which would leave some of them to go to Dr. Google and speak to friends and relatives and other people that they thought they would trust for information. And the meaning of this towards MRI period is really that a tension between hope and, I guess, gaining answers or positive information about maybe recurrence of disease or the lack of recurrence of the disease, versus a real existential anxiety about gaining understanding about that illness and what that might mean for their future selves. So the participants arrive in this vulnerable and anxious state, and during the MRI, each participant describes some very shared characteristics of their experience. One relating to space and time in particular. And space and time are indivisible. But if you think of it, actually, when we move, then we move through space and time, and that is quite an important feature of each of the participants' experience. So from a space perspective, then obviously MRI is smaller, and the participants describe a world which is shrinking and feels smaller, even if they don't have claustrophobia. And this limits their ability to move, and is they describe as being hostile and therefore confined space, and that combination makes them feel trapped. But also they have altered perception of time, and if you think that apart from very few more modern scanners, the participant cannot monitor time themselves, there's no time cues, only coming from the MRI practitioner in that space. And so time also becomes dilated and abnormal and lasts longer. So I guess objective and perceived time are very different. And so that combination makes the individual feel confined and feel trapped. They also participants describe the space being psychologically, physically and emotionally very isolating, which leads to an emotion of feeling alone. And because of that restricted nature and trapped nature, they all described an inability to act and a sense of loss of control. And so therefore there's a power imbalance that all of the participants shared when talking about being within the MRI environment. Several of the participants describe feeling invisible whilst in the MRI scanner and feeling de-identified by the process. More unique findings after talking to the participants were each described a heightened negative embodiment, so being highly conscious and attuned to the body's sensations and feelings, I guess reinforcing some of those negative bodily experiences that they might have, but also negative emotions whilst in this particular space. So they were feeling pain, the feeling of trapped and being isolated heightened that sense of pain, and that became their sole focus, often really demanding their attention. Additionally, several of the participants described being very conscious and aware of being under a medical gaze, so that this sort of the fact that they were attending and being looked at by a practitioner, but also by the machine, and then also, I guess, vicariously by their referrer whilst being at the scan, and that would result in this internalization of their own gaze inside their body. And several of the participants describe actually visualizing maybe their tumour or their disease process and what the medical images might look like whilst they're undergoing their scan. And there's this anxiety around having to, I guess, confront their disease process whilst undergoing this kind of medical gaze. So exploring my participants' distress during the MRI, being distressed was not a static construct and not a singular state or a specific temporal moment. Rather, it's very dynamic, and it obviously can increase and decrease over time. And the nature and level of distress varies from individual to individual and from situation to situation, depending on if their context changes. For example, Julie, one of my participants, had undergone a large number of MRI scans in her past, and she'd always found them very trivial and found them at the no distress end of the spectrum, both pre, during and post. However, during a more recent MRI scan, she felt very trapped, and she got to the point where she'd experienced terror and panic and had to stop the scan. And then since then, she's had multiple scans since, even that when she'd referrer talks about sending for MRI, she feels extreme anxiety and fear. And so she begins now on the continuum of distress at a much more heightened level, even before she goes into the MRI scanner, perhaps compared to past, because the context has changed. So a dualistic view of distress, where the individual is either distressed or is not distressed, is very overly simplistic and perhaps inadequate to understand this dynamic nature of their lived experience. I think this also shows that during the scan, as a practitioner, you're able to potentially increase or decrease the participant's distress based on how we might interact with them as well. So what we've seen so far, MRI distress is quite complex. It's multifactorial in origin. Only two of my participants would describe themselves as claustrophobic, and clearly there are many elements, both psychological, emotional and physical, which are contributing potentially to the individual's distress, and therefore they're very individual and intersubjective. However, two characteristics, or two categories I perhaps would say, of distress were being experienced by my participants. Some, not all of them experienced both of these, but several of them were experiencing perhaps both of these types of distress. So there's one being an anxiety, a very future-focused anxiety, which really focused on the results, which was happening during the scan, a sort of a scan anxiety, perhaps if you may, and then a more immediate fear, which could then precipitate and lead to potentially to terror and panic. So very immediate and overwhelming existential kind of threat. So we'll just unpack both of those quickly. This existential anxiety was not a feature of every participant's narrative. Very internalized, very future-focused state, perhaps triggered by being in this heightened awareness of the body, but also being very aware of being under a medical gaze, where the individuals were left to confront their illness and their vulnerability and thinking about the impact of the findings and what that would mean for their future selves. Max provides a great example here. When you are in the machine, then you've got nowhere to hide your thoughts. Go to that anxiety of whether something new is going to be found. Know that you are being scrutinized, and whether you like it or not, it does feel like you are on a knife's edge in terms of an emotional state of trying to hold it together. All the participants shared an experience of, I guess, unbearable tension to endure distress during the MRI, to gain information about their illness or symptoms. So even though they maybe don't all talk about existential anxiety, it perhaps suggests that they all indirectly do contemplate the meaning of their scan results while they're being scanned. The second category of distress that the participants experience in this space is fear. And this is a very intense state that is very externally directed towards the MRI machine, the procedure, the environment, as this hostile, very immediate existential threat where the individual feels trapped. And this is the embodiment of fear. It is not somebody that is just claustrophobic. In fact, the person can have no claustrophobia at all, but can feel trapped in this space because that's the language of fear. A lot of the participants use death imagery to describe their experiences and talk about being in a coffin and being cremated. In fear, the individual feels highly vulnerable and they have a diminishing capacity for themselves to have cope and to have agency. And then if the individual becomes overwhelmed, they will cross this threshold on that continuum of distress to the point where they precipitate to terror. And it's really a one-way ticket once you pass that point, and the person becomes consumed by terror, and then they are in full panic mode and in flight. This experience is extreme, it's deep, it's pervasive, it's absolute existential threat to survival. Julie provides a powerful description of the totality of her terror. You read A Point of No Return, where I've got to that point to feel I'm fighting for my life. It's a genuine fear that you have to get me out of here or I'm going to die. This imagery reveals her powerlessness and complete lack of agency in this moment and expresses, I guess, a sense of hopelessness. What I would also like to convey is that several of the participants were experiencing extreme distress, yet this can be silent and invisible, therefore, to the MRI practitioner. Several aspects of the MRI experience and process were felt as dehumanizing. Central to all dehumanization theories is a denial of human mind and agency to another person, which can be prevalent in medicine and high technology environments, including MRI. Hack and Watts describe 6 forms of dehumanization with healthcare, and these are quite relevant to MRI experience and are summarised in this table here. For my participants, a particularly important finding that emerged was the relationship between the individual and the imaging practitioners. All my participants described experiencing negative interactions with staff, at least during one MRI visit. This included a lack of information sharing or not feeling fully informed about the process. All participants described feeling like an object or experiencing a machine-like process, which resonates with mechanistic dehumanization, with a loss of capacity to act and make informed decisions about oneself and reduced agencies. These experiences include a loss of dignity and humanity, feeling like being just another number on a conveyor belt, feeling anonymous, losing identity. The experience was often described as very passive, and that staff were just going through the motions. Very few participants received recognition and reassurance that their feelings were common and a normal response to the MRI experience. Some described that their feelings were brushed off, were dismissed, or even resulted in the MRI practitioner expressing frustration when they shared, resulting in individuals experiencing an acute need for human support and contact that they felt was not met. Examples provided that they wanted human touch, create more conversation and rapport, developing an interpersonal relationship and trust, a greater need of empathy. For all of my participants, the experience in MRI was one that was clearly traumatic, and perhaps we should consider this a form of medical trauma, a trauma that occurs from direct contact within the medical setting and develops a complex interaction between the patient, medical staff and medical environment that can lead to powerful psychological longer-term impacts. My participants regularly described experiencing a sense of embarrassment and falling to shame or feeling a sense of failure at the end of their scan particularly if they were unable to complete. All participants described some form of avoiding post-care procedure, where emotional and information needs were not fully met, with the lack of validation often for the individual's negative experiences. Several participants described feeling discarded and abandoned at the end of their procedure. Some of the participants had much longer long-term effects. For example, Julie has developed claustrophobic-like tendencies, which she now leads to a resultant avoidance of MRI and other medical procedures. Other participants described ongoing emotional and psychological distress that was quite significant and had lasted for periods of time from days, weeks, months, perhaps even to years, leaving them feeling angry and indignant about their care or a lack of during the MRI. In an Australian setting, medical radiation practitioners have a capability that requires them to recognise and respond to the deteriorating patient. This includes recognising and responding to acute deterioration physiologically, but also in cognition and mental state. My findings perhaps point to that patients can experience significant distress in MRI. This could lead to deterioration in their mental state, and this is an area that we perhaps have little consideration routinely in an MRI setting. We've looked at some of the key findings from my PhD. We've not had time to look at coping strategies, which were very complex, individual, and developed over time. We can see that distress in MRI is very complex, but also very personal. And it also can be mediated in part or not by the MRI practitioner too. There is also a very significant power imbalance within this MRI setting for which we have to acknowledge and respond to. I would like to acknowledge that MRI practitioners work in a highly demanding, time-poor environment with high operational demand. However, there should not be a trade-off between care and efficiency. It's important that practitioners do value humanity and recognise the critical importance of human interaction within this environment, and that we can make a huge impact on patient experience even with a small amount of time. For my PhD participants, many of them just wanted to be seen, wanted to be heard, to be given information and agency where possible. There is clearly a need for increased research, education and training in MRI-specific person-centred approaches. There is also much greater need for co-design and co-production with consumers. I'd like to also point out for some of the images which have been created through ChatGPT that we'll have to presume that this MRI stethoscope is conditional, and so is the stool. A huge thanks to Everything MRI for my time to share my qualitative research, to my supervisory team Rachel and Marguerite, and to the 8 participants who graciously talked about their distressing experience. If it looked like I've had a haircut, it is because my neighbours were doing building work, so I had to record this in 2 parts. And I look forward to taking your questions. Thanks a lot.
Thank you so much, Jonathan. First of all, well done for introducing such a delicate topic to our wider community. I was particularly impressed when you showcased all the emotions that patients tend to experience during their MRI scans. Feeling like losing control, being in this sort of hostile environment, and also having an altered sense of time. And let me say that sometimes as MR users, we tend to approach this with a certain degree of detachment, but the reality is this can happen essentially to anyone. And I remember my personal experience when I volunteered for protocol optimization in this very old small bore MRI scanner, and I felt like I was spending days inside this confined space, and gradually my only hope became to having someone take me out to the scanner as soon as possible. And yes, because indeed we are the MRI practitioners, and yes, we are those coordinating service provision, but one day we might also be those being inside at the center of that ball. So you might agree with me that empathy in this sense is key. Having said that, let's go ahead with our amazing lineup. The next speaker I'm very glad to introduce is Sigrid Berg van Ruijen. Sigrid brings a wealth of experience from her clinical background. She has witnessed herself the inefficiencies in various healthcare systems in both private hospital, public hospital, but also clinical research settings, and even in countries with top-tier healthcare systems. For this reason, she has become a strong advocate for the use of AI and big data to help healthcare organizations in recognizing the benefits of integrating these new tools to improve their overall processes. In this sense, Sigrid firmly believes that embracing new technologies is key to the future of healthcare, with AI in particular showing great potential to enhance treatment outcomes for both patients and clinicians. As some of you might be aware, we had at Everything MRI an event early this year completely focused on AI integration, and I believe today we have the opportunity to add further value to that discussion with Sigrid's presentation, whose title is Transforming the Patient Experience, the Role of AI in Radiology. Sigrid, whenever you're ready, please go ahead and take the lead.
Hi, my name is Sigrid, and I'm going to talk to you about how AI in radiology can transform the patient experience. But first, what is AI? We've heard a lot about AI now the last years, 1.5 years, after ChatGPT was introduced. I think the more general population has gotten an idea of how AI can transform and that AI is a thing. But the fact is that we've been using AI for much longer than we actually realize. If you think about, for example, the spam filter on your email inbox, or when you're navigating from place A to B, or these home assistance tools such as Siri or Alexa, and facial recognition, all of these tools are AI. The thing is that now we also have and I think ChatGPT has kind of helped us with that. But now we have AI in healthcare and radiology as well. And that's a bit more unknown. So today I'm going to talk to you about what it is, how it can impact patient experience, and lastly, the ethical considerations and what future prospects could be. But first, what is AI in radiology? So AI refers to computer systems that can perform typical tasks that typically require human intelligence. That means that you've collected all these type of data and that you've trained a model on, and now you have something that can either detect a pattern, it can automate some tasks. And AI in radiology typically analyzes medical images to assist diagnosis and treatment planning. But when you look into the medical image analysis, it really processes large volumes of imaging data quickly and identifies subtle patterns. It can do image segmentation, it can do lesion detection, but also workflow optimization. So Carla, a 54-year-old woman, a mother of 2, is due to her mammogram screening. Carla's healthcare facility has recently implemented AI into AI-assisted mammography system. And while processing her images, an AI algorithm analyzes them and is able to detect a subtle change compared to her last screening. This change would have been challenging to detect with the human eye. Within a couple of minutes, the AI has flagged a small suspicious area for the immediate attention of the radiologist. Reviewing the image, the radiologist can confirm the presence of a small mass that could have been easily overlooked at its early stages. So the radiologist can focus on the specific region and make an informed assessment. Because Carla has been it's been detected so early, future tests reveal that she has stage 1 breast cancer. And the early detection improved the prognosis. She was able to have quick therapy and treatment, and she had a quick recovery. And this is the essence of AI in healthcare. So it really can help with precise detection. It can detect and classify abnormalities in medical imaging with high precision. It can help with pattern recognition, patterns that we as normal human beings or even experts are not even able to see. And it can also help us see new patterns and help with early detection of conditions. And that will improve the patient outcomes. And I think this, knowing how AI can help in interpreting and reducing these variabilities in interpretation can really help the patient experience. Imagine it shouldn't matter whether you're going to hospital A or B, what type of diagnosis you're getting or what type of treatment you're getting. And AI can help with standardizing these things. There was one example from Denmark many years ago where they started looking into the breast cancer treatment across the country in the different hospitals. And every hospital, they thought, well, they were doing quite well. And there was one specific hospital, they never thought they had any issues. But suddenly comparing them to other hospitals, they realized, wow, we're really doing bad compared to everyone else. Why is our treatment so much worse and the outcome of the treatment so much worse compared to the other hospitals? This was not done by AI, it was just comparing and having some standardized treatments afterwards. But AI can help to do this even more, even further, across departments, at one hospital, or across different hospitals, across different regions, across different countries. So you can imagine that you'll be able to figure out what the best treatments are, what are specific parameters that could be able to improve treatments, and all this for the better of the patient. So it should really not matter where you live, what type of treatment you get, or what type of, whether you're able to get a diagnosis or not. Next to being able to have, work with the diagnostics, AI can also help with streamlined workflow and efficiency. So imagine any type of task that is, a bit boring, some tasks that are just annoying to do, or that are just these repetitive tasks. AI can help with automating these, such as image sorting, prioritization, and measurement. Regarding prioritization, I used to work in a hospital, and I remember this one specific case of a patient I was consulting. And I wondered, first of all, why on earth am I consulting her? I did not understand. And eventually I figured out that she had been calling the hospital and eventually my manager so often to demand a consultation with us, even though we were fully booked, say, for the next half year to a year. And it was difficult getting a time. But because she was calling, she climbed up the prioritization line. So she got a time or a consultation with us very quick, while other ones were deprioritized. That annoyed me a lot. And AI can help prioritize urgent cases without having this human interference in between, and it can also improve the turnaround times. Next to that, it can also improve reporting. So automated reporting to generate reports for radiologists to review. That would also shorten, the time. Paper flows are going back and forth, so that the doctors, so the GP could get the outcome of a hospital visit. What is important for these things, though, is that it really should save time for healthcare professionals and not increase the time we're spending on things. So it's important for the ones working on AI development to actually ensure that the way the new tools are suggested will save you time and not increase time. So it's both for the ones developing AI tools to be critical on this, but also the ones implementing it to be critical to how it will potentially save time and benefit to you. But in many cases, it can. But with this, especially with the reporting and stuff, there are a lot of automations and a lot, especially now, with GPT up and not just coming, it has come. There are so many potentials for it, but we need to make sure that it is efficient enough to use in the clinical workflow. So 10 years ago, my dad was diagnosed with leukemia. A few days after he started chemotherapy, his organs were just running overtime. He was put in an induced coma, and a few days later, one organ after the other just started shutting down. 2.5 weeks after he started his therapy, he passed away. It's not that this is an example of radiology, but it has something to do with personalized care and patient care, because what actually killed him was not the cancer, it was the treatment. He could not handle the chemotherapy. And I believe that if we had the AI tools available back then, they might have been able to see that based on his medical history, based on his genetics or lifestyle factors, he should actually have had another type of therapy. Even though chemotherapy was a standardized and the standard therapy for his disease, he could not handle it. And the weird thing is, one of my friend's dad passed away by the exact same thing. So it's not unique, but they don't know what. But I think that AI will be able in the future, one, to detect the reasons why someone cannot handle a specific treatment, but also define what type of treatment people should have based on certain factors. And there's so many more things that AI can do to personalize patient care. So, for example, tailoring assessments. So, analyzing the patient data for personalized risk assessment or screening recommendation. Imagine as well looking into all the medical data, or just thinking about all the medical data that we've had and covered and collected over time. It's been masses and masses and masses of patient data, but we don't have a structure of looking into it. We do not know a quick way of getting an overview of this patient, unless they only visited the healthcare or like been in contact with healthcare 2 times in their lifetime. But you don't have a good way of knowing actually what happened with this patient. AI would be able to help with that, being able to summarize patient histories, putting up and visualizing this to people, or just writing short summaries, instead of healthcare professionals having to look through this and using minutes and not hours just to have an understanding of what happened with a patient and what they should be focusing on. But also, when you do know what's happening to a patient, what type of medical history they have, and you're able to get a quick review of this, you're able to focus on the patient when you're talking to the patient. You're able to give them the care they should have. You're able to give them the empathy they should have. And also create these comprehensive profiles, integrating these clinical data for a better patient profile. This combined with a type of new diagnosis or what type of treatment one should have, that could really impact what type of care the patient should have, and personalizing that treatment for them. It could also estimate disease progression and treatment response for individualized care. This is a bit what I talked about as well with my dad. But really looking into the medical, just the medical background, medical history, all the information that we have, and highlighting maybe patterns or risks, and not just for treating someone here and now, but also preventing disease. And there are so many ways that AI can be powerful and useful for patient care, because the moment you're able to give patients quicker treatment, faster treatment, better treatment, then you can start thinking about how that would impact the patient. They're going to be less in the hospital, they're going to be less sick, they're going to have quicker recovery, and it's going to cost less for the healthcare organizations as well. So it's really, as a whole, that we can think about, it's not just only going to benefit the hospitals themselves, but also the patients, if done right and well. Next to just personalized care, AI can also help improve the communication of results. So imagine there's so many healthcare jargons and way of saying things, And it can be difficult for the normal person population to understand what's actually happening, what's happened to me, what type of diagnosis do I have, what type of impact will this have? But first of all, AI can generate clear and structured reports highlighting key findings and recommendation. Not only that, it can also do it in a normal language. Instead of having a complex name for some type of knee surgery, it will be very clear to that patient they have to go through knee surgery. And that makes it much clearer for them and for them to understand what they can expect. And the time to explain this to patients will be much faster. Or they could have it, you know, on their phone or on writing that they do understand. AI can also help create intuitive 3D representations of imaging that can be useful for both healthcare professionals, but also for patients. Being able to both communicate and, like what I mentioned before as well, summarize medical histories, and so that the healthcare professionals can focus on the patient, can also help the healthcare professionals to come across more empathetic towards the patients. I have so many examples of stories of personal experiences or from others who have been in contact with healthcare and they have not been treated in an empathetic way. And I think that is because there's no time, and there's no time to fully understand the patients or their surroundings. But there's also no time to be empathetic. But if we're able to take away some of these tasks, daily tasks, so that the healthcare professionals can actually spend more time, quality time with the patients, that's what I would like to see. And I know a lot of healthcare professionals, they can be a bit worried that AI will, you have to be more effective, you have to treat more patients. And I don't think that is the goal. And I think if that is the goal, someone up in the system is looking at it wrong, because it's not about treating more patients, it's about the quality the patients are getting. Looking into radiology further, AI can also assist with image acquisition. So it can improve the comfort of a patient going through a scan, so MRI scan or CT scan or whatever. It can make the whole process more comfortable and convenient for the patients. So faster scans can, for example, be done by AI optimization of imaging protocols, and automated adjustments can reduce scan times, but it can also minimize the time that a patient needs to be still. And by improving the image quality, you can also reduce the rescans, you can improve the quality of it, and reduce the likelihood of patients needing to go back to the healthcare facility to repeat an imaging. And you might even be talking about personalized protocols, so tailoring imaging parameters for each patient based on characteristics, and potentially reducing discomfort and anxiety. Secondly, you can improve the safety. So optimizing radiation and contrast dosage could, by AI to help determine the optimal dose for contrast agents or radiation, so you would minimize unnecessary exposure. So that would contribute to a safer radiology experience, both for the patient, but also for the healthcare professionals. And by improving accuracy, so imagine that you'll be able to have higher quality images. So your AI is able to reduce the noise and improve the resolution to produce clearer and more detailed images for accurate diagnosis, or more consistent imaging. So automating the position, for example, or what type of parameters adjustments to have more consistent scans across different patients. And technologists, it can reduce the variability of the scans and make it easier to interpret. But also, if you use these images for future AI algorithms, it will make it even easier to detect some type of patterns. So AI can really just help with that, the acquisition of the images, and improve the quality and the outcome. Then you have predictive analytics in radiology. So I mentioned these imaging medical history that you could collect. Combining this with new data, it could really give an idea of the disease progression. It could give you the idea of what will be the best treatment as well, but also have early detection of disease. So it identify early signs of conditions before they're even clinically apparent. It can identify patients at risk and help prioritize patients as well. Which ones should have follow-up, which one should have specific treatments, and which one would have successful treatments. So based on that, who would need a follow-up, or who would need to spend longer time in the hospital or shorter time. So it's again pulling it back to this personalized treatment as well, because you will be able to have it much more personalized than you've been able to do before. There are some ethical considerations when it comes to AI and AI explainability. And one of the things is transparency or explainability, sorry, that will help, would really help for when you use AI in the healthcare system. So first of all, you want to know, why does the AI suggest something it suggests? Why does it say something it says? Why should we take it serious? And what does, how did it come to a conclusion it came to? This is a big challenge, because as healthcare professionals, we don't always know why we make a decision we make. It's not always black and white. In some cases there are, but for some cases it's just a gut feeling. So how do you expect explainability from an algorithm when we cannot explain the reason why? But on the other hand, you also don't want it to be a black box. You want to understand, and you want to know why an algorithm says what it says, why it suggests a treatment it suggests, why it suggests a diagnosis it suggests. So as much as possible, we do want to know, and we do want to understand why it made the decision, or the decision-making process it had. Secondly, there's bias in algorithms, unfortunately. So bias is based on the data it's being given. So an algorithm is giving a lot of data. And if the data is from, for example, from one type of hospital or one type of population, this can result in bias. A quick example is there was an algorithm being trained for, I don't know what type of cancer, but they had to detect a cancer from MRI scans, I believe it was, and they had two different type of hospitals they got the scans from. They had one, university hospital or medical center, and they had one more of this local hospital. Eventually, the algorithm was able to detect that one of the brands was a higher likelihood of cancer than the other brand. So say Siemens, if you had a Siemens scan, then it was a high risk of cancer. If you had a GE scan, it was a low risk. But that wasn't because of that was actually correct, but it had seen that there were more cancer from the university hospital with the Siemens scan than it was in the local hospital. This is a very clear example of bias, but bias can be so much more or worse. If you have a population, and unfortunately a lot of the data we use for AI training is based on Western data. So if the population you train on is not really diverse, how will it be if you have someone from another country or from another background? It can really give this potentially unfair results based on this training data. Another example, also non-radiology, was from the Netherlands. They had a bit of a big issue with this some years back. They used an AI tool in the government to detect fraud in subsidies for daycare. And what this AI detected was that most people, families with an immigrant background, they were fraud risks, like a risk of fraud. So they had to pay back the subsidy they've gotten for the daycare. That was not correct, but still the day-to-day, they're still struggling with this, getting their money back, that the families are struggling getting the money back that they had to pay to the government. This bias, though, is not only based on the demographics. It can be, but it can be based on demographics. But the data that we pull into these algorithms or train the algorithms with is based on our bias. So if we have bias towards certain groups or towards certain populations or demographics, this bias is also going to be shown in the algorithms. There are so many examples of bias in this, and we have to be aware of this. We have to make sure that we reduce bias as much as possible, but also when using it, we need to be critical about this, whether or not this is a biased result or if actually correct. And it's this constant struggle because you do want to trust the AI enough, and we need to make sure that the AI is trustworthy enough to be used in healthcare settings. But on the other hand, you also want to make sure that you're critical enough towards it and can make your own decisions. It's a fine balance because you need the AI to be efficient enough so that you can, reduce the workload, and trustworthy enough so that it would actually be used. But also, if something would happen to that algorithm or something would happen with electricity and would just shut it down, that you can still continue your work. And with all this data being used for both training, but also when you're gonna use the algorithms to detect the disease, for example, there are large data sets with personal data being used. So you need to make sure that the privacy and the security of this data is taken care of, that we make sure that we have measures to protect this data that will not have data leakage and potentially harm for patients. And lastly, there are many things I could discuss with ethical considerations, by the way, but lastly, what I want to discuss today is the liability. And these are difficult questions of who are responsible for the AI-assisted diagnosis errors. It doesn't need to be necessarily diagnosis, by the way, but any errors made by AI. Would it be the manufacturer of the AI? Would it be the doctor who's treating that patient? And how do you make sure that the liability is fair, but also that the patients are protected if there are any errors? These are all discussions we need to have. These are all discussions we need to make sure we have tackled in a good way before we massively start implementing AI that can impact patient outcomes. Because often as well with AI, you don't want, we are not there at the stage right now that AI can take any decision and will just be fine. It's not that smart. It does mistakes. It has bias. So we need to have someone human as well involved in it. But on the other hand, we need to make sure that we can use it in a trusting way. So that we both protect the not just the privacy, but also protect the patient's well-being and their that we just keep them in the center of anything we're doing. Thinking about the future and the directions that we will have and the patient benefits, I think we have just started to see small parts of what AI can be doing. We already discussed personalized treatment, but I think the more data we will have, the more structure we will be able to have it, and the more we will be able to pull out from this data, we'll be able to enable more precise and personalized treatment planning. We might even be able to develop new type of imaging biomarkers. But also for the patients, so you would have improved patient engagement. So patient-facing AI tools can help improve health literacy, because that's really bad in Europe. I think it was like 1/3. I don't. 1/3 of the population is not health literate, or maybe it was the other way around, but I think it's quite low anyway. And it can help them understand more around their disease and what's happening. It would also help to improve the access to expert radiological opinions. So not just in the Western world, but also the places that it's not easy to access in developing countries, that you'll be able to, AI could help facilitate remote diagnosis. So in any place that you're not able to have a radiologist, imagine you'll be able to work with these type of AI tools to just improve the diagnosis, improve the treatments, and improve the patient outcomes, because you're able to detect things much, much earlier than before you can see something sticking out of their neck. So AI is not only for the Western world, where AI is not only for the developed world, it should be for all, and should be benefiting all, and should not only be benefiting the rich and the wealthy. So I just want to thank you for your time. If you do want to know more about AI in healthcare, or radiology specifically, or how that can be used and improve your healthcare facility, please feel free to reach out to me at sigrid@irhealth.ai. I'm happy to discuss with you and see if I can help. For now, thank you so much.
Thank you so much, Sigrid. That was an amazing discussion. I'm very glad you shared these insights with us, and especially your mention about AI playing a key role in improving the communication of the results. Sometimes it seems all we hear about AI in MRI is how nicely it enhanced the image quality, or how it reduced the scan time. But the reality is there are many areas where this technology can be used, and where it could be a game changer, because the fears and the concerns of the patient aren't just related in spending the time in that small claustrophobic environment, but sometimes they also come from receiving reports they might not fully understand. And I'm not sure if this happened to you as well, but it happened to me, having friends or family members back home coming with their reports asking, is this really bad, right? And this confusion often comes from the amount of complex terminology that is used, making the interpretation quite difficult. And having AI making more MRI friendly, patient friendly reports, I think could be quite a lot of advantages in the long term. Okay, let's move now to our third presenter of the day, and I'm very excited to introduce Ruth Evans, the Managing Director of the Patient Experience Network, also known as PEN. Ruth brings over 35 years of experience in healthcare, and is widely recognized for her passion and dedication to improving the patient and customer experience. Her ultimate goal is to ensure that excellent patient experience is not only recognized, but also shared and embedded, making a real difference for everyone involved in patient care. I'm personally very glad to have Ruth here today, because we usually stretch the importance of going back to the basics for different aspects of MRI, and I believe the same should be done when it comes to the patient experience. So with a presentation titled The Case for the Patient Experience, what it is and why it is important, ladies and gentlemen, let's pay close attention to what Ruth is going to share with us.
Hello, my name is Ruth Evans, and I'm delighted to be here today. Before we get going, I thought I'd share with you this image, and I wonder if anyone knows where this is. If I tell you it's in Eastern California and it's in the Mojave Desert, maybe you know now. It's one of the hottest, driest, lowest places in the world. And back in 1913, they recorded temperatures of 57 degrees centigrade and 49 degrees in the shade. Yes, it's Death Valley, and it's called Death Valley for a reason. As you can see, virtually nothing lives there. And yet, Even the harshest, driest conditions can be transformed under the right circumstances. And as you can see here, every now and then Death Valley transforms into a place of beauty. And it's called a super bloom. And once about every 10 years, it rains. And it transforms Death Valley into this place of beauty. And I wonder if it may feel a little bit like Death Valley in your workplace at the moment. You're working under some of the hardest conditions, under some of the most difficult circumstances. And yet, how can we ensure that we create the right circumstances so that you can have your own super bloom? We know through our patient experience awards that many organisations can still do beautiful things despite the circumstances. And so I wanted to share with you some thoughts today. In my presentation, I'm planning to do a little introduction, which I've done now, give you a potted history of patient experience, and then start to think about why it's important. I know many of you are already perhaps experts in experience, but I thought it's always worth reflecting on why we're here. And then have a little think about some of the small things that might make a big difference. Before we do that, though, I thought you might like to know a tiny bit about PEN. The Patient Experience Network was founded in 2010, and we set ourselves up to really celebrate, share, and recognise best practice. And when we do that, to enable organisations to measure, embed, and sustain for continuous improvement. We do a whole range of products and services to support organisations, and you can see some of them here. And our work, again, we've had a whole range of projects, but I've just included 3 here so you get a sense of who we are. So we run the National Patient Experience Awards, and we have been doing so since 2010, and that's a real celebration of good practice. We run specific projects for individual organisations, so we will support organisations who want to improve their experience, and that could be a strategic or a very specific focused area issue. And we work across organisations and create collaborations to improve together, to be better together. Right now, we're in the middle of our Patient Experience Awards for 2024, and although the shortlist has been announced, our winners will all be presenting on the 3rd of October, and you'd be very welcome to join us. Please head to our website if you'd like to know more. That's enough about PEN, I think. So I wanted to just have a little reflection on the history, if you like, of patient experience. And for many people, you may be thinking about Lord Aridazi as one of the founders of patient experience, and he is an important person. But actually, I just wanted to go further back to this lady. This is Florence Nightingale, the Lady of the Lamp. And I find it fascinating because we often think of patient experience as being quite a recent context or idea. But actually, back in 1850, she realised that patients needed to have a great experience to improve. So she created the Invalid's Kitchen so that they could cook food to enable people to be nourished and have a better experience. She created a laundry to ensure that cleanliness was key. But she also understood that people needed to be occupied. So she founded a library and created an opportunity for people to be educated so that they could have a better experience and have a better outcome. So we often think, as I said, of Lord Darzi, and actually in current times, he was one of the first people to give patient experience equal footing, if you like, with safety and clinical effectiveness. And he wrote a white paper that was issued in 2008, identifying that patient experience was a third and important part to ensure that patients had the outcomes that we want them to. Another important luminary in patient experience is Kate Granger. And Kate Granger was a doctor who became a patient herself and identified through her own experiences that often it was the small things that really made a big difference. So she identified that communication was important, and she launched the Hello, My Name Is campaign because she found that many healthcare professionals simply forgot to introduce themselves. And when you have introduced yourself and you now know that I'm Kate, you're Ruth, you can have a different conversation. It's a more person-to-person conversation. And it was also important to see beyond the disease and see the patient. We'll come back to Kate. So what is patient experience? We often talk about patient experience as if we're all understanding the same thing. And I wanted to spend a little bit of time reflecting on what is patient experience. And we have a definition at the Patient Experience Network, and we call it the sum of the patient's experiences during their care. And it's a function of the services that they receive. So it is their personal experience. It's not something that we own. It's something that is actually what happened to them. And it's not necessarily what we want to have happened. It's not necessarily the process that's been documented, but it's what actually happened to the patient. And it is also a function of what matters to them. So did they receive the level of care that mattered to them? And I think with patient experience, we sometimes focus on the outcome, which of course is important, or the input. So how do we change the input? But actually the experience is that sweet spot in the middle, which is what the patient experienced. And of course, the inputs, the things that we do as colleagues and as an organisation impact the experience. And if we get that right and the patient has a great experience, that will have an influence on the outcomes. But it's the middle bit that is the experience. I think when we talk experience, it's also important to understand that when we get it right, we can have a radical impact on important outcomes. This piece of research came from Aston Business School, and it was one of the first pieces of research that was done in the UK. So there'd been a lot of evidence of the impact of patient experience coming out of the US, but this was one of the first UK-based pieces. And this identified that when we get the experience right and when we engage with our patients, we can have a dramatic impact on key outcomes. And in this case, the key outcome was mortality. So you can see the green bar is where you have higher engagement, and you can see that when you've got higher engagement, you have a reduction in the mortality rate. And we see this time and time again in our examples, in our case studies through our patient experience awards. And we saw it in Northumbria, for example, who focused on the experience patients were having of their hip operations. And they also saw a dramatic improvement in the mortality rates as a result of focusing on the experience. And when we're talking patient experience, I think it's important to also understand that we're thinking about colleague experience. And so the inputs, what are we as colleagues doing? And there's a really interesting piece of work. And again, this has come out of a paper that was done quite a while ago and has been adapted. So this is from James Heskett's paper, which was focusing on the service profit chain, as it called it in his paper. But this is a deep understanding that if we actually need to start with our people. So if we're going to focus on patient experience, we're better thinking about our people first, because if we get it right for our people, and you can see that I'm talking all of our people, so our healthcare professionals, but also the management infrastructure to enable them to do their jobs, and also the technical and support processes that enable them to do that. That has a direct impact on our patients' experience. And our customers, and in there I'm including the commissioners as well. And if we get that right, then we have a direct impact on key outcomes. And you've seen mortality as one, but there's a whole range of other important outcomes, including reputation, absenteeism, retention, length of stay in hospital, a whole range of really key outcomes. And actually, it's shown as a linear relationship. So there is evidence now to show that if we can improve our colleagues' experience, that will directly impact and improve our patients' or customers' experience, and that will then in turn have a direct and positive impact on some of these outcomes. But actually it's a circular, it's a virtuous circle, because if you then do that, then of course you've got efficiencies and other improvements that enable you then to go back and invest more in your colleagues and so forth. So it's a really powerful model, I think, this one. And so thinking about the model, well, what are the characteristics of excellence? So where do we want to focus, and what are the small things that might make a big difference? And this was a piece of research that was done by the Institute of Customer Service. And I think it's fascinating because it talks about the characteristics of service excellence. Now, this is characteristics across a whole set of different industries, including healthcare, but not only healthcare. But it came out consistently that to be excellent at what you do, to deliver a great experience, there's 4 things that you need to do well. And the 4 things were these: that the people are seen to go the extra mile, that they are making it personal, and I think that's where Kate Granger's work really starts to have an impact, that they're delivering the promise, they simply do what they say they'll do. And then if you've got a question or a complaint, that these are handled brilliantly. And I think this is fascinating because this isn't rocket science. These are things that are within our control often, and certainly within our influence, of things that we can do to make a difference. And if we have a look at the research in healthcare specifically, we see that this is underscored by work that's been published by NHS England and PICA, amongst other organisations. And it shows that patients are very similar, because what they're looking for is they want to be involved, they want to have their preferences respected, they want to feel that their emotional needs have been looked after, they want to feel informed, supported and listened to so that they can make meaningful decisions and choices about their care. And they want to be treated as a person and not as a number. And we saw that again in Kate's work. And PICA have gone on to explore, well, what does this mean? If we're going to deliver a great experience and be excellent, then we need to be person-centered. And through their work, and actually indeed through our work, we have identified that there are 8 principles, 8 key things that we need to focus on to get it right, to be person-centered, which enables us to deliver a great experience. And these are shown on the screen, and they're around being fast and giving fast access to reliable health advice. So whether it's planned or unplanned, urgent, emergency or elective, having fast access. They want effective treatment delivered by trusted professionals, and this is right across the board, so healthcare professionals, but all professionals that they'll meet along their journey. They want continuity of care and smooth transitions. So it doesn't necessarily have to be the same person, but that the information is being the right information and the information that matters to the patient. They want involvement and support for their family members and carers. And they want clear communication and information and support for self-care. So they want to be able to be self-directed and self-managing. They'd like involvement in decisions and respected for their preferences. And respected also in terms of emotional support and empathy. And the final one is that there's attention to the physical and environmental needs. If you'd like to know more about these, they are on the PICA website. But we see these principles coming through time and time again through the winning submissions in our Patient Experience Awards. The last piece of the puzzle that I wanted to focus on today, and again, is thinking about breaking the complex and making it feel simple, and really working out what we can do, so the art of the possible. How do we create our super bloom, and what can we control and influence? And I think sometimes when we're thinking about the patient journey, it can feel complex, but actually we should be breaking it down into 3 simple stages. There's the warm welcome, the perfect process in the middle, and then the friendly farewell. And there's a lot of evidence that shows that if we get the end bits right, as long as the middle bit's not too bad, and there's nothing terrible has happened in the middle process, then people will tend to remember the first and the last, the primacy and the recency effect. And actually what we need to be thinking about are, well, what are our brilliant basics? What are the things that we always want to do? And what are the things that we never want to happen across this? So, for example, if we think back to Kate Granger and the characteristics of service excellence, maybe one of the things we always want to do is make people have a personal welcome where we've introduced ourselves and we've seen them and not just their disease. And if we get this right, and I know that many people refer to this this saying from Maya Angelou, and I think the reason they use it is it's so powerful and so relevant. And it basically says that often people will forget what you said, they'll forget what you did, but they won't forget how you made them feel. And at the heart of all of this is how we're making our patients feel and how we're focusing on being person-centered to give them the experience that matters to them. So as I wrap up and starting to think about, well, what does all of that mean? And you're going to hear some other great presentations. What is it that you can do? What is it that was in your gift? What is the art of the possible? How are you going to create your own super bloom? How will you know that you've done it? How are you going to measure yourself? And what are you personally going to commit to? And as you're thinking about this, perhaps as you're listening to the rest of the presentations, what are the things that you want to do to improve the patient experience? And keep it simple. Just focus on 1, 2, or 3 areas. But don't forget that actually it's also around your colleagues. So how are we going to make sure that our colleagues are also having a great experience? Because we know that if we get it right for our people, we're more likely to get it right for our patients. And if we get it right for our patients, they're likely to have better outcomes. So thank you very much for listening. And I'd love to have any questions.
Well done, Ruth. Brilliant presentation. This will give us plenty to discuss during our roundtable. One aspect that particularly caught my attention was your mention to the various characteristics needed to achieve service excellence, and especially the importance of effectively managing complaints and queries. And this, in my opinion, highlights the need for patients to be able to provide feedback. As a practice, we might have sometimes gaps of things that we might have overlooked in our systems, or just simply things that require improvement. So establishing a solid process where the patient can easily provide feedback and, of course, to raise a complaint if anything goes wrong, I believe is essential to enhance the overall patient journey. And speaking about the patient journey, we are proud today to have here with us Dr. Darren Hudson. Darren is the MRI clinical lead for InHealth, a leading diagnostic provider in the United Kingdom. He brings extensive expertise in MRI, overseeing quality, governance and training for MRI radiographers within the organization, along with being certified in MRI safety by the American Board of Magnetic Resonance Safety. Darren is also deeply passionate about improving the patient experience in MRI. And in this regard, huge kudos to him for just completing a doctorate in clinical research, where he has explored the use of virtual reality as a preparatory tool for MRI. His work continues to drive innovation and support the workforce development in this field. Today, Darren will discuss the main concern affecting patients during their MRI examinations, concern that, as we already seen, as MR practitioners we encounter daily, but for patients these are quite unique emotions that require careful approaches. So without further ado, I present to you Dr. Darren Hudson and his presentation, Journey to the Center of the Board, Patient Experience in MRI.
Hello there, my name's Darren Hudson and I'm clinical lead here for MRI across InHealth in the UK, and I also work part-time in the School of Psychology at the University of Exeter. Thanks to Samuel for inviting me to speak this evening, and thanks to Ruth for setting the scene on patient experience so well. Before starting on to the main content of my presentation, I thought it might be quite useful to provide some quick background on who InHealth are, just to give a bit of context as to what has allowed us to conduct some of the work that I'm going to talk about, and gives a bit of wider background behind the staff and the patients that we work with that have informed our patient experience work. So InHealth is the UK's largest provider of diagnostics. We've got over 30 years of experience with the NHS, and we operate over about 800 plus locations with about 100 magnets within the UK. So we've got a large fleet of mobile scanners, but also an array of static units within the community setting and acute locations. So we see perform about 4 million tests across all modalities each year as well. So a large access to patients that we see over that period. So the plan over the next 10-15 minutes or so is really for me to give you an overview, a very whistle-stop overview of some of the work that we conducted in preparation for my doctoral thesis, really looking at the current situation in practice to try and support the need for any ongoing interventions that we were working on. There is a lot of content, so please do check out these articles if you're interested in any further information. And really what I'm going to look at, or what we have looked at with those papers, is what factors actually influence the patient experience. We looked at their journey through MRI itself, and also what matters to them when undergoing an MRI scan. All with the intention of this really helping us to understand the impact of their experience on them, and also how we can further enhance our provision of support to improve their experience even further. If I have a chance at the end, I will then also just touch point on some of the research that we continue to do and work on within this space as we move forward. So patient anxiety isn't uncommon and unusual within medical imaging in general. There's a reported incidence across all modalities to varying degrees, but as much as 95%. But obviously undergoing an MRI itself can be specifically a source of anxiety and fear, and is well documented over the years that it's been in clinical use. Heightened anxiety has previously been reported in about 18 to 56% of patients that attend for MRI, and it's about 3 times or more than 3 times likely to happen compared to somebody undergoing an ultrasound scan, unsurprisingly. One of our studies, we actually looked at and asked radiographers their perceptions on the occurrence of anxiety, and overwhelming 92% of the respondents stated they see it on a daily or weekly basis. So this hasn't really changed over the past 10 years. The severity of anxiety can be variable and is mostly low, but there can be severe responses. It very much depends on the individual, and we tend to see a severe anxious response in around 1/3 of patients. But even when we talk about the severe response, most tend to manage the scan. There may be some adaptation that's needed, maybe a compromise in image quality, but the majority of times we will get a scan done and patients through the procedure one way or another. Obviously, what triggers this anxiety can vary. Often it's down to the nature of the equipment, but it can be things such as the prior experience, having stories from other people, any concerns they may have over their diagnosis, and obviously the demands of the procedure itself, such as having to lie flat or being in pain, just to name a few. When we ask radiographers as well, they consider themselves to be well attuned to recognising the behavioural signs of anxiety when patients attend. Again, this is variable, is very much dependent on the individual, but they're commonly related to what we would expect human responses to stress and fear to be. It isn't always obvious as to what degree somebody may be experiencing a sense of anxiety, particularly if they can manage it and they can cope with minimal to no signs of distress. Common things we tend to look out for are obviously patients being restless or agitated, excessive questioning or inquiry into what's happening, or they can be overly talkative, distracted, or overly rude and aggressive. We've all had those patients that attend particularly rude as they go into the scanner, and then they come out a completely different character due to the fear subsiding and altering their behavioural response to the situation they're in. We also see physiological responses as well, particularly the tendency to need the toilet more often, typically just as we're about to call them for a scan, but also noticeable sweating or changes in breathing as well. So really it's important that when we think about these signs of anxiety, that radiographers are aware of these and can recognise them, and then take that cue as an indication that we need to obviously modify our approach to try and provide the enhanced support that that individual might need. So more often than not, the expression of that anxiety or discomfort is claustrophobia. It's often due to the physical nature of the equipment, or at least if it isn't actually because of the equipment, we put it down to being claustrophobia, even though there could be another cause. And I think it's an important thing to remember that we focus on the physical nature of the equipment, but actually there are other reasons that can cause that level of fear or distress for patients that are coming to have a scan done. Looking at claustrophobia itself, this is a situational phobia of enclosed spaces, and within the general population we've got a prevalence of around 2%, and concerns are really specifically related to either the fear of restriction or a fear of suffocation, and in understanding which part of that may be affecting a patient can obviously be quite useful in terms of how we might adapt our technique or interventions may be most useful. As well as that, it's often around the fear of being trapped or unable to escape as well. And whilst we might think of that as being a fear of restriction, actually there is a slight difference there. And actually that term of claustrophobia is a different type of phobia as well. So again, understanding what's driving somebody's concerns is actually quite important, even though those two terms have become synonymous over time. Obviously for the individual, the implications of an experience of claustrophobia will vary, again, as I mentioned, in terms of anxiety in general. For some, it can mean that they can't tolerate a scan at all. Some don't turn up. That's a reason for some DNAs. Others, they may abandon partway through, or even for those who can tolerate a scan, there may be degradation of image quality, there may be patient movement. It may take a lot of effort for them to manage that in the first place. And ultimately, if they have completed to us what is the aim of the scan, i.e. having the scan finished, any negatively perceived experience can obviously have an adverse impact on the patient themselves, having to come back again, their diagnosis, any onward management and other bits and pieces, and their further interaction even with the health system as they go through their journey. Operationally, obviously what we often think about is the issue this can have in terms of our productivity, our throughput, cost, lack of revenue, wasted scan time, and those kind of things as well. And when we look at what obviously affects often the most inducing parts of anxiety, again from the literature it's well evidenced that actually that first sight of entry into the room can be a big source of heightened anxiety because it's a very alien environment, and then also those positioning and placement into the scanner tends to be the second trigger point along their journey as well. So reported incident rates of scan-related claustrophobia vary, and it very much is probably, like I say, more common than we actually realise because people tend to manage it and can control any discomfort they might be feeling. But one thing that we often look at operationally to measure is incidence of incomplete scanning. So where a patient attends but they're unable to complete the study, we look at this data to see how things have moved and see whether there's slight variation and what may be causing that. Obviously, there's a limitation there in the sense that it only captures those who actually can't complete the scan. It doesn't actually capture those who can, but obviously struggle to do so. Again, we conducted a review over 2 years, looking at about 650,000 patient attendances. And our overall incomplete scan rate was very low. It's down to 0.76% over that patient group, with a DNA rate of about 4.3. And there are some interesting things between that where we looked at different services. So actually, compared to an open scanner, you're more likely to have a claustrophobic incomplete scan almost 4 times on an open scanner compared to a conventional magnet, whereas conversely, going to one of our upright magnets, you're half as likely to have an impact. And there's an important thing there around the physical nature of equipment in terms of whether you're lying flat, whether you can see a mechanism for escape, which again comes back to that whole concept of restriction or being able to escape as being the driver behind that fear. Unsurprisingly, head first scanning increases the odds of incomplete scanning, whether that's a head or neck scan or just entry into the scanner itself. And there are important things that are to also note regarding age and obviously patient gender as well. But over that review, the cost implication was about 550,000. Now, actually, just in the cancelled appointment itself, actually, if we extrapolate that over to the NHS and the figures and the throughput that we looked at in that period as well, a very conservative measure just based on appointment time alone is about 3.2 million cost to the NHS. So whilst we are talking few numbers and it's not a massive figure, that's still a substantial amount of money that could obviously be diverted or used elsewhere if we can encourage and support patients to get through and have their scan done that they need, not to mention their individual benefit in terms of proceeding and having a diagnosis, knowing what to do and carrying on. Another interesting thing though, so whilst there is a downward trend and it's under the 1%, when we could do some site comparisons, interestingly, even those old scanners with a 60 centimetre bore, they still performed better than some of the 70 centimetre newer systems. And that suggests, that physical nature is one thing, but there's other things going on in terms of that interaction that might be having an impact at the same time as well. And really, because of that, these technological advances, quicker scanning, use of AI, improved environments, etc., we're still yet to fully realise them to their maximum effect. So whilst we've got a downward trend, we haven't maybe got as far as we could be if we had new scanners across all locations and across the NHS that would maximise those benefits further. So to further understand the experience beyond the data, as I say, that only tells us so much. We've also looked at the patient journey through MRI. So we consider these under 3 stages from beginning to end. Each has a role in the anxiety that can be perceived and different aspects that we can influence this. So we often think about the warm welcome, so the appointment, the waiting, the positive procedure, so obviously having the actual scan itself as well as preparation, and then the fond farewell, which is leaving both the scan room and obviously the department. And a real benefit of breaking down these stages into these three areas is we can actually appreciate two other effects. So we can think about the primacy effect, which is essentially the first impression of a service, and the recency effect, which is the last impression. And so as long as the middle bit, so the positive procedure, and that goes okay, is actually the patient's perceptions are either one or both of those ends. So we often call them the bookends of experience. They are the things they will recall and will ultimately influence their perception of their experience and what feedback they give or how they rate their experience or tell other people. So again, it's a useful way to remember that, and to think about, actually, as long as we do the bit in the middle okay, it's the other bits that really have an influence that we can try and do a bit more around to try and improve their experience. And actually, when we've mapped this and tracked it across those stages through their journey, and so this is actually asking patients, how anxious do you feel as they've gone through different elements of their process. The key thing really coming out of that is that the warm welcome is often not considered so warm, and that's where the anxiety is often greatest. Perhaps unsurprisingly, the unknown, not knowing what to expect, also a lot of things out of our control, so the frustrations over parking, waiting lists, booking processes, etc., etc. But again, when we look at this in line with the wider literature, where anxiety tends to be more heightened, it tends to be entry into the scanner itself, and that sense of being abandoned and alone within the scanner, which again comes back to, I think, more of that claustrophobia driver around unable to escape, as opposed to actual restriction or suffocation itself. The other aspect we've also worked on was to understand further is what actually matters to patients when they come for an MRI scan. So again, across two different studies internally, with over 300 patients, the most important thing time and time again is about making it personal. So how we communicate with patients, how we provide assurance, and how do we show we care. Being informed is second to that. So how do they know what to expect, how long things will last? And ultimately, the results we've got from these studies really informed our own definition as a business as to what do we think patient experience means. And that really encompasses the importance to patients around timely, informed and personal interactions. To try and get a deeper understanding around what matters, in particular, how we can use this to enhance satisfaction, we also looked at another study where we actually took a model from the customer service called Carno's model, to try and actually understand what characteristics or elements of the service actually can increase or have an impact on satisfaction. So essentially with the model here, we have things that we can use that will increase satisfaction. So again, things at the bottom here that we call must be. Having them doesn't necessarily increase satisfaction significantly, but not having them will dissatisfy. Attractive items, not having them, they don't notice, but again, the more you have them, the more you can enhance their satisfaction. And then one-dimensional, so again, having them will improve satisfaction, not having them will dissatisfy. And when we looked at that and we mapped that across the grid here, so we had 600 patients who responded to this survey. We can see that underneath the line here, so these are things that will dissatisfy. A lot of these are actually functional aspects of experience. Whereas if we look at the right hand side of the line here, these are things that are more likely to have an impact on satisfaction and improve it. They tend to be much more relational in nature. So this is where we have our greatest opportunity to add to that satisfaction and therefore the experience as well. And this table further breaks down those elements and reinforces how these relational elements are actually beneficial. And at the end of the day, for most, interaction and information can never be too much when they come in for their experience and going through their process. So with all that in mind, one tool that we have developed over the years is a simple communication framework to act as an aid memoir. And this is really not a prescriptive way to follow in, it's more a guidance around what staff should be thinking about and what are important touch points in their interactions with patients. It was adapted from ADET, which was developed by the Studio Institute in the States some years ago, and essentially we've modified it slightly in terms of acknowledge. So acknowledge patients with a smile, the introduction. So we're obviously using the campaign in the UK from Kate Granger around Hello, my name is. It's about describing what's going to happen, explaining what is happening, and then providing reassurance throughout your interaction. And then when we think about the ending, it's around what's going to happen next. How do they get results? And and we talk about thank, which is less of a thank in terms of what we might be thinking about from a customer service point of view, but essentially it's around finishing on a positive note. So any way we can do that when they finish the interaction, as we go back to the what we spoke about with the patient journey, that positive farewell or the fond farewell at the end can actually leave them on a positive note, and therefore makes the whole reflection of their experience a much more positive one as well. And this does draw on other research. So this is some work that was done by Mann et al. In Australia, and again it aligns with this action research around the elements of an experience and interaction that can really be supportive and beneficial for the individuals going through a scan. So what else can we do, as particularly when we think about person-centred care? So if we go back to the 8 principles from Picker, perhaps the 2 big areas which have influence over, we have influence over, are really around the provision of information, that clear communication, and around that ability to be able to provide emotional support, empathy and respect. And really these are what we want to be looking at in terms of can we modify and adapt those to the individual requirements to help them cope and manage a scan. So any intervention, when we look at what we can do for patients, is not around curing their claustrophobia or anxiety at the end of the day. It's not about a treatment, it's about finding a functional means of them managing their emotional response so they can actually cope and manage the situation. We can think about this under 4 kind of categories. So situational, so can we adapt the technique? Can we use adjuncts? Can we scan them prone, feet first, head first, those kind of adjustments? We think about attentional strategies. So in our world, we're thinking about music, distraction, use of the headphones. We can modify their response. So that's generally through the use of medication like anxiolytics. But we can also look at their cognitive approach and therefore reappraise how they reappraise the situation they're facing. So again, if we compare the means of support used and their effectiveness between RADs and patients, on the left we've got what RADs thought, and on the right we've got patients. And again, we can see generally they're very congruent in their agreement in terms of the on-the-day conversation and communication over the intercom, both in its use and obviously how effective it is. Beyond this, their perceptions vary and they do drift and differ slightly. So the use of music and information are considered beneficial by patients, whereas they're less so by radiographers. And there also appears to be an over-reliance on the use of anxiolytics by radiographers compared to what the views of patients think in terms of their effectiveness. So I think anxiolytics is an interesting driver. This has been a long-standing approach for a long time, and I think in practice it's an easy option in terms of the side effect of time pressures. So if someone's claustrophobic, you might be running late, we haven't got the time. Actually, if we can pass them back on to somebody else to get medication and rebook them, it's a relatively easy fix and simpler on the day. So that's something we're seeing internally a lot of pushback from GPs and referrers around prescribing. And actually, again, when you look at what the patients say, that's not something they particularly want either. So looking at alternatives is important. Ultimately, the key approach for patients is really around control over their experience. And if we can achieve that through choice, even false choice. And then the most commonly cited barrier really from radiographers' point of view was really around the barrier to providing support is the lack of time and that time pressure to do more in less time. And so that's another consideration that obviously is going to prevent what we're trying to achieve in terms of person-centred care and that patient experience within MR. I'm just conscious of time, so I'm going to skip over to this the next couple of slides here. So I think really to summarise, I think what we've learned or looked at from the updated information that we've achieved over the last few years is really, despite the developments in technology, this isn't an issue that's gone away. It has reduced, and we've definitely seen it reduce over the time I've been in MR, but it still remains an issue at the moment that needs to be managed and addressed to be able to support the patients coming through for their appointments. Obviously, the impact is variable, particularly on the patient themselves, but also on the service delivery. And obviously, with that, we can't get away from the cost, both to the individual, but actually the cost to the healthcare system is another reason why we need to be thinking about this and how we can be managing it. Being informed on what to expect is a key way of managing that and changing their coping mechanism. And there's some challenges over time pressure, which is obviously something which I don't think there's an easy answer to, but there are things we could potentially look at how we do that to try and manage that better. And it's around trying to avoid this over reliance on anxiolytic medication and looking at non-pharmacological solutions. So it's an evolving area. A lot of the data we've done more recently supports older data, but essentially it's something we need to continue to understand as we move forward, so we can see how technology is influencing things. Is it improving stuff? Is it giving the extra time back that we need to provide the support we might need to for the minority? And also the other consideration, so as we think about services moving away from the traditional hospital-based delivery, how is that having an impact on their perceived experience in a setting that may be more designed and amenable to outpatients compared to in an acute setting? Again, I'm going to share some of these slides with Samuel to share afterwards. But otherwise, thank you very much for listening.
Amazing, Darren. Thank you so much. And let me say that it's fantastic at this stage of the discussion to have some solid data to support these findings. Congratulations for doing this research. To me, this clearly stretched the importance of establishing effective communication with patients. And let's be honest, sometimes when scanning 25, 30 or even more patients per day, it shouldn't happen, but it's easy to get distracted, rushing through the scan, shortening the explanation of the examination, or even forgetting completely of speaking with the patient via the intercom. And this can have a huge impact on the overall patient experience. Some patients might just abandon the scan after a couple of sequences because they feel completely isolated. And just simple updates like letting them know how much time's left for the examination, or just simply quick feedback like, hey, you're doing great, very good images so far. Just this simple feedback can provide like a huge level of reassurance, making a huge difference for the overall patient journey. And this guides us to the final lecture of the event before meeting all the speakers to the roundtable for this amazing Q&A session that we're gonna have together. And I'm very glad to introduce today to you Selena Glenn, the founder of Concha Consulting. Selena is an accomplished MRI radiographer known for her expertise in MRI patient care. She holds a master's degree in health and wellness, specializing in integrating holistic practices into MRI care. And she's also a sought after speaker presenting at major radiology conferences such as the Radiological Society of North America, the European Society of Radiology, and the Japanese Society of Radiologic Technology. As a traveling clinical MRI radiographer, she has worked with numerous clinical and medical facilities on a national scale, implementing and improving new protocols and sharing her overall knowledge and expertise. Selena will try today to dive completely into the patient perception in MRI through an accurate analysis of the psychology within the MRI journey itself. So with the title MRI Psychology, I'm very glad to leave the stage to our final speaker of the day, Selena Glenn.
Welcome everyone to today's forum on MRI psychology. My name is Selena Glenn, and I've been a radiographer for 30 years and dedicated MRI technologist for over 14. My passion for exceptional patient care has driven me to specialize in understanding the psychological aspects of MRI patient care. Today, we'll explore how MRI psychology can transform patient experiences and improve the efficiency of our work. Let's get started.
I don't like MRIs.
Don't worry, I will take good care of you.
I'm sure many of you have encountered this situation. Let's explore MRI psychology and the possible reasons behind MRI anxiety and the solutions to address it. Here are our learning objectives for today's presentation on MRI psychology. First, we will define MRI psychology and why it's crucial for enhancing the patient experience. We'll explore the impact of MRI patient anxiety and examine the physiology behind it. You'll identify common anxiety disorders that MRI patients may experience and discover the top causes of their anxiety. We will also recognize additional factors that contribute to this anxiety. We'll review the various types of MRI anxiety interventions available and appreciate the broader implications of this knowledge. Additionally, we'll cover good customer service basics and techniques for coping with work stress. These objectives aim to provide you with a comprehensive understanding of MRI anxiety and how to manage it effectively. Now, let's define MRI psychology. MRI psychology is the study of the psychological factors that affect patients undergoing MRI scans. This includes understanding anxiety, claustrophobia, possible causes, and other stressors that patients might experience. But why should we consider this? Why consider MRI psychology? I discovered a significant gap in MRI training. Traditional programs focus on the technical and scientific aspects, often neglecting patient care. Simply put, it's essential because patient anxiety can significantly impact the success of MRI exams. High anxiety levels often lead to incomplete or poor quality scans, which then require repeat procedures. This not only affects the patient's well-being, but also increases healthcare costs and operational inefficiencies. Who benefits? Everyone benefits. Patients, technologists, and healthcare providers. Patients experience less stress. Technologists can perform their duties more effectively, and healthcare providers receive better diagnostic images. MRI psychology contributes to the field by enhancing patient-centered care, offering evidence-based strategies to manage anxiety, and providing insights into how the MRI environment affects patients psychologically. This integration helps us innovate and improve the patient care practices and experience. Why is MRI psychology education important to the patient experience? Understanding MRI psychology enables technologists to recognize different anxiety disorders. This helps technologists empathize with patients, identify signs of anxiety, and apply effective interventions. This results in greater patient comfort, higher completion rates of MRI exams, and fewer repeat scans. This not only improves the patient experience, but also makes our jobs easier and more rewarding. Next, let's explore the significant impact of anxiety on patients undergoing MRI scans and discuss strategies to mitigate these effects for improved patient care. Let's look at the anxiety prevalence and impact. Anxiety is a common issue in MRI environments, with up to 40% of patients experiencing some form of anxiety, and technologists observing anxiety in up to 71% of their patients, with significant impacts on the scanning process. With approximately 20% of exams are prematurely terminated due to panic attacks. MRI anxiety affects various demographics differently. Studies show mixed results on gender, significant anxiety in younger and older age groups, and variations based on nationality and economic status. For example, women and individuals from higher economic statuses tend to report higher levels of anxiety. Younger adults, ages 25-45, and older adults, around 60 years, show significant anxiety levels, while children often require sedation due to high anxiety levels. Internationally, anxiety prevalence rates may vary across different regions and countries due to cultural factors, access to health care, and awareness about MRI procedures. For example, anxiety levels may differ between developed and developing countries based on factors such as healthcare infrastructure and patient education. Anxiety significantly impacts the patient experience, leading to delayed healthcare, triggering no-shows, and early termination of MRI exams. These issues disrupt medical treatment plans, causing delays in diagnosis and care. Effective management of MRI anxiety can help improve patient outcomes and overall satisfaction with the healthcare process. Technologists face numerous challenges due to patient anxiety, including disrupted schedules, increased aggravation, and compromised exam quality. These issues can lead to longer workdays, higher stress levels, and a potential decrease in job satisfaction. The financial impact of MRI anxiety extends to patients, technologists, and imaging centers. Canceled exams result in lost revenue, increased operational costs, and potential implications for technologist pay. For patients, the financial burden includes additional transportation costs, childcare expenses, and potential income loss due to time off work. For technologists, operational costs increase and profits decrease every time an MRI exam is prematurely ended, which may affect your pay in the future from budget constraints, potentially impacting bonuses, raises, and overall job satisfaction. Imaging centers face significant losses from wasted appointments and increased operational costs. For example, a study found that worldwide there was a 2% cancellation rate due to claustrophobia, which resulted in nearly 2 million MRI exams being canceled and sustained an estimated loss of 1 billion euros, which equates to approximately 1.4 billion US dollars. Now that we have the basics of MRI anxiety, let's dive into the top 10 factors causing MRI anxiety. Understanding these factors is crucial for providing compassionate care and ensuring a positive patient experience. Number 10 on our list is radiation exposure. Despite MRIs not using ionizing radiation, some patients mistakenly believe they do, leading to anxiety. Coming in at number 9 is the fear of needles or contrast injections. For some, the idea of needles or allergic reactions to contrast can provoke significant anxiety. Number 8, being too large or heavy for the MRI scanner. Patients worry about fitting into the machine comfortably, sometimes fearing they might damage it or get stuck. At number 7, we have miseducation. Lack of accurate information and exaggerated stories from friends or media can contribute to patients' anxiety about MRIs. Number 6, loss of control. The feeling of vulnerability and lack of control inherent in being a patient can significantly contribute to MRI anxiety. Coming in at number 5 is the requirement to remain completely still. This can be challenging for active patients and those with involuntary movements, leading to anxiety, which is why I allow patients to tap their finger or wiggle their toes whenever possible. Number 4, fear of being left alone or autophobia. Patients may worry about being left unattended during the exam, feeling vulnerable without someone nearby. Number 3 on our list is loud noises. For some patients, the loud sounds of the MRI can be distressing, even triggering panic attacks in those with PTSD. At number 2, we have fear of the unknown. Uncertainty about the MRI process and potential outcomes can lead to significant anxiety for patients. And not surprisingly, the top cause of MRI anxiety is claustrophobia. The fear of enclosed spaces can be overwhelming for many patients, making MRI exams particularly challenging. In this section, we'll discuss common anxiety disorders, their symptoms, and the physiological aspects of anxiety. We'll also explore additional factors that contribute to anxiety in MRI. Physiology of anxiety. Before we dive into anxiety disorders in the MRI environment, it's essential to first understand anxiety physiology. Anxiety primarily involves the fight or flight response of the limbic system, which is where our emotional reaction to something takes place. This system regulates our emotions through neurotransmitters like serotonin, GABA, epinephrine, and norepinephrine. The first stage of the fight or flight response is the appearance of the threat. This could be the MRI machine itself or walking into the waiting room. Once the brain confirms the threat, the amygdala is activated, followed by the hypothalamus. The pituitary gland secretes the hormone adrenocorticotropic hormone, which in turn triggers the release of cortisol and adrenaline that causes several physical effects. These physical effects include increased heart and breathing rates, slowed digestion, and a relaxed bladder, which is one of the reasons anxious patients always have to urinate. Patients may also experience dilated pupils, tunnel vision, loss of hearing, and body tremors. Anxiety can also cause dry mouth and reduce blood flow to the face, hands, and feet, which can explain why some patients become thirsty and have a pale appearance. Conversely, blood flow increases to the brain, arms, and legs, preparing the body for a rapid response. Common anxiety disorders. Generalized anxiety disorder, or GAD, is a mental health condition characterized by persistent and excessive worry about various aspects of daily life, such as work, health, and social interactions, lasting for 6 months or more. Worldwide, the prevalence of this disorder can vary widely across countries, ranging from less than 1% in some countries to around 8% in others. It affects about 3% of the U.S. population. Patients may experience uncontrollable worry, impacting their ability to undergo MRI scans, accounting for 32% of MRI exam failure. Generalized anxiety symptoms include chronic headaches, sense of impending danger, irritability, muscle tension, restlessness, sleeping problems. Stomach pain and diarrhea, fatigue or weakness, increased heart rate, difficulty concentrating and hyperventilation, sweating and or trembling. Claustrophobia, or the extreme fear of small enclosed spaces, is the primary cause of MRI anxiety. Patients may experience catastrophic thoughts and panic attacks, making MRI scans difficult. Symptoms include sweating, a sensation of butterflies in the stomach, hot flushes or chills, a rapid heartbeat, tachycardia, shortness of breath or difficulty breathing, trembling, chest pain or a feeling of tightness in the chest, and a choking sensation, feeling sick, headaches and dizziness, numbness or pins and needles, feeling confused or disorientated, ringing in your ears, a need to go to the toilet, a dry mouth, and feeling faint. A panic attack is a sudden, intense episode of fear or anxiety with physical symptoms. Panic attacks consist of primary and secondary symptoms. The primary symptoms include a racing heartbeat, feeling faint, dizzy, or lightheaded, and feeling that you're losing control. Trembling, sweating, or shaking, and shortness of breath or breathing very quickly, hyperventilation. Secondary symptoms include feeling sick, nausea, hot and cold flashes, and numbness, pins, and needles. Next, we're going to look at agoraphobia, the fear of situations where escape might be difficult or help unavailable. Unlike people who suffer from claustrophobia or panic attacks, where there is an urge to flee a perceived dangerous situation, agoraphobic patients simply avoid stressful situations altogether and may contribute to MRI appointment no-shows. There are 3 types of agoraphobia symptoms: physical, cognitive, and behavioral. Let's take a look at agoraphobia physical symptoms, Some are the same as those of a panic attack, although some differ. Similar symptoms include feeling hot and sweaty, trembling, rapid heartbeat, feeling faint or dizziness, feeling sick, and rapid breathing. The physical symptoms unique to agoraphobia, which include chest pain, diarrhea, ringing in the ears or tinnitus, and difficulty swallowing, dysphagia. Cognitive symptoms are feelings or thoughts that may or may not be related to the physical symptoms. Cognitive symptoms include feeling having a panic attack will embarrass them or make them look dumb in front of other people. Having an uncontrollable fear that they will not be able to escape from a place, such as the MRI bore, if they have a panic attack. Feeling they may die from a panic attack. For example, they may worry their heart will stop or cannot breathe. Feeling as if they are going crazy. Feeling as though they may not be able to control themselves in public. Feel they need others' help in order to function or survive. A fear of being left alone, known as autophobia. This can also be applied to being left alone in the MRI scanner, which, if you remember, is number 4 of the top 10 causes of MRI anxiety. Now, let's look at the behavioral symptoms, which includes never going too far from home, avoiding situations that could lead to panic attacks, such as an MRI exam or public places, and inability to leave the house for long periods of time. PTSD, though less commonly discussed as it is not an anxiety disorder, yet it can significantly affect MRI patients. PTSD results from traumatic events and causes upsetting symptoms that can be triggered by the MRI environment and may be a major contender in causing anxiety and prematurely canceled exams. PTSD symptoms may include vivid flashbacks, reliving the traumatic event in the present moment, intrusive thoughts or images, disturbed sleep from nightmares or a lack of sleep, intense distress at real or symbolic reminders of the trauma, physical sensations such as pain, sweating, nausea or trembling, constantly feeling on edge or hypervigilance, being easily upset or angry, difficulty concentrating, including on simple tasks and following directions, and jumpiness or being easily startled. MRI technologists play a crucial role in understanding and anticipating factors that may cause patient anxiety. By recognizing the medications and pre-existing conditions that may contribute to anxiety, technologists can provide better care. Let's explore these factors. Understanding anxiety-inducing medications is crucial for MRI technologists. Some medications have side effects that include anxiety affecting patients during their MRI exams. This information can usually be found in the patient's medications list. First, let's look at the top 7 medications known to cause anxiety. 1. Corticosteroids. 2. Caffeinated medications. 3. ADHD medications. 4. Asthma medications. 5. Thyroid medications. 6. Seizure medications. 7. Parkinson's disease medications. Beyond medications, various pre-existing medical conditions that can usually be found in patient charts can contribute to MRI patient anxiety. Let's explore some of them. Heart diseases, respiratory diseases, diabetes, and substance use disorders. Hint: patients scheduled for a pituitary exam may experience more anxiety. People with disabilities may experience anxiety during MRIs. Examples include visual or hearing impairments, mobility issues, cognitive disabilities, and developmental disabilities. Being sensitive to their needs is crucial for providing patient-centered care and the patient experience. Next, we'll explore some of the tried and true techniques along with some of the latest advancements in MRI anxiety interventions. Hint, keep in mind that each patient is unique and may respond differently to interventions. Sedation is the most popular intervention for managing MRI anxiety, with a 94% completion rate. However, alternatives are necessary for those who can't use sedatives. If a patient's medication isn't working yet, note that oral sedatives like alprazolam, Xanax, and lorazepam, Ativan, usually take up to 1.5 hours to be fully effective. If the patient took the medication less than an hour ago, it's best to wait before starting the exam. Comfortable patient positioning alleviates MRI anxiety and pain. Please use the available pads to ensure the patient's comfort, as this reduces motion and makes the process smoother for everyone. Patient education is crucial for managing anxiety. Informative videos and materials help patients feel prepared and in control, reducing anxiety, motion artifacts, and cancellations. Additionally, environmental changes like better lighting, airflow, and call buttons improve comfort and control. Here's a hint. To improve the patient experience, refer to the call button as the communications or call button instead of a panic button. Research shows music therapy calms the mind and body, reducing MRI-related stress and lowering blood pressure, heart rate, and cortisol levels. Many patients find it soothing, with feedback like, calmed my nerves, and soothing and relaxing. If you have access to this effective intervention, please use it. It works. Combining breathing techniques and aromatherapy can quickly relieve MRI anxiety. The SIGBA technique, which I developed, merges these methods. In a 2021 study, 39% of patients found breathing techniques effective, while 74% reported reduced anxiety with lavender aromatherapy. My study showed a 77% reduction in MRI anxiety using SIGBA, enhancing patient compliance. Aromatherapy with essential oils is low cost and effective. Just use the patient-chosen oil and a piece of gauze near the patient's head. Now we are going to look at how technology can enhance the MRI patient experience. Augmented reality, AR environments, can significantly reduce MRI anxiety by immersing patients in calming virtual landscapes, leading to a 65% reduction in anxiety. However, AR setups can be costly. Another approach is integrating infotainment systems into MRI machines, allowing patients to watch movies or TV shows during scans. This method boosts satisfaction and reduces anxiety for 80% of patients, though it's also expensive and not widely accessible. Good customer service in MRI patient care with cultural sensitivity is essential for reducing anxiety and improving the experience. Building strong rapport between MRI technologists and patients enhances comfort and satisfaction. The relationship between patients and MRI technologists is crucial. Trust and clear communication reduce anxiety and enhance patient experience. Addressing concerns like MRI anxiety improves scan quality, leading to more positive patient experiences. A warm initial interaction sets the tone for a positive patient experience. Using a script helps build trust and address concerns before the MRI scan. Technologists across the U.S. find these scripts enhance patient rapport and experience. Providing support during the MRI is crucial. Regular updates, especially for phobic patients, and reassuring statements like, "You got this," or reminders to breathe calmly, help manage anxiety and reduce motion artifacts. Continuous comfort monitoring is essential, as discomfort can impact scan quality. Maintaining communication keeps patients informed and reassured. Allowing patients to wiggle a toe or tap a finger away from the scan area can reduce anxiety and pain. Although it seems counterintuitive, small movements help alleviate pain and stress from staying still. Since being told not to move is a top cause of MRI anxiety, reassuring patients they can make these small movements without affecting the scan improves comfort. Post-procedure care is crucial for a positive experience. Discuss the timeline for results to manage expectations. Thank the patient for their cooperation and ensure they have no immediate concerns before leaving. Next, we explore how prioritizing the technologist's well-being enhances the patient experience. Let's delve into the key factors that contribute to a positive MRI environment. MRI technologists often face significant psychological challenges, including high stress levels, emotional exhaustion, and even anxiety, depression, and burnout. Studies indicate that 45% of MRI technologists experience high stress. Burnout is a state of physical, emotional, and mental exhaustion caused by prolonged stress. Symptoms include fatigue, irritability, reduced performance, and sleep disturbances. It significantly impacts MRI technologists, with 39% reporting symptoms affecting their well-being. To maintain well-being, MRI technologists should prioritize self-care through setting boundaries, practicing mindfulness, seeking support, ensuring adequate rest, and taking your breaks. These strategies are essential in preventing burnout and fostering a positive work environment while improving the patient experience. Technologists' well-being directly influences the patient experience, fostering better interactions and enhancing comfort and trust. Research shows that 72% of patients feel more at ease when their technologist appears calm and composed. Summarizing, understanding MRI psychology is vital for improving patient care and reducing anxiety. Addressing MRI-related anxiety enhances the patient experience and outcomes. Recognizing anxiety factors and managing symptoms with tailored strategies is crucial. Incorporating the psychological aspects in training bridges knowledge gaps. Using traditional methods, advanced technologies like AR, and complementary medicine offers a holistic approach. Good customer service management and prioritizing technologists' well-being are essential for positive patient experiences.
That's it. I hope you have found this presentation and the information within it useful in enhancing the MRI experience within your facilities. Before I go, I would like to tell you a little bit about Conjust Consulting, my company's services. Our services include consulting on MRI patient care, customer service management, health and wellness, conflict resolution, education, research, and our new online mini MRI consultancies tailored to help find solutions and optimize the MRI patient environment. These at minimum, 1 hour segments of consultancies are available not just to management, but radiographers as well. I would also like to tell you about my ebook that's now available in an interactive format. It is an excellent addition to the patient care section of any MRI curriculum. You can find out more about my book and services on my website. I want to give a special thank you to Everything MRI for this opportunity and for their ongoing support. I look forward to your comments and questions during the Q&A session. Thank you. Be well and choose happy.
All right. Thank you so much, Selena. Thank you again. And I have to say, it's very nice to see at this stage of the event that there are already some key themes that are coming out, like the fear of losing control, the concern of being in this sort of confined, hostile environment. And I also, let me say, I particularly love the mention you made about the fear of the unknown. And this perfectly connects with what Darren or Jonathan said about the importance of effective communication from our side as a healthcare professionals. But I think to a certain extent, it also like links perfectly with what Sigrid was saying about the fear of what's next. It's not just being there, but it's also like being afraid of an unexpected result or perhaps not understanding such a result. Having said that, let me just give me just a little bit of time to thank all the speakers for sharing these fantastic insights. And probably you can imagine there are a lot of questions. So kudos to Samuel that tried to keep track of all of them. To be honest, I missed the count at some point. So I don't want to waste any further time. I will hand over this to Sam, who is going to introduce the roundtable, which is probably the most anticipated moment of our event, where all the speakers are going to gather and we're going to try to tackle together all the questions related to improving the patient experience. So, Sam, I can see you there. What are your thoughts, what we have seen so far today?
Thanks, you, Julian. I think we had amazing presentations. We spoke about psychology, anxiety. We did some research. We went to AI. There's a lot of questions about all of these topics, which are very engaging. So we'll have, for sure, a great roundtable. I want to mention a few things as well. So first of all, for example, on Selena's presentation, we're talking about pads. So I want to bring one of our sponsors, Pearl Technology. They do amazing pads as well. So nice segue there. There's a lot of things that each one of the speakers mentioned. That one of the questions was about the entertainment systems and changing the rooms and all of that. So I'll bring that to the round table as well, but we have our major sponsor, PDC. So guys, I'll share the link on the comment box so you can actually see their website, and it's really amazing what they're doing in terms of changing the environment when the patient comes in to reduce those anxieties, that agoraphobia that Selena was mentioning, and all those fears that we have when we're having this kind of scans. So we also have a sponsor from Do Reality, a VR simulator. Darren was mentioning VR tools to help the patients, but we also need to help the radiographers dealing with those patients, because we have a lot of claustrophobic patients that a lot of radiographers don't know how to deal with them. So I think these VR tools are important for both of the cohorts that we're talking about here. So yeah, we have those sponsors. I'll put them on the link. And also, Julian, we have two things to tell to our community before we jump in.
Quite exciting.
So one of them, I'll let Julian speak about the other one, but one of them is we have another event like this happening in November 19, and we have, I would say, the best speakers around the world. I think I'm being fair, Julian, to speak about MRI safety. So we had one last year, and we're going to have another one 19 of November. So please just join us there. Julian, do you want to give the other news that we have before we jump into the roundtable, please?
Yeah, absolutely. So we have already partially communicated this, but we are launching our very first cardiac MRI course, particularly dedicated for radiographers. So if you are an MRI radiographer and MRI technologist that want to learn how to do cardiac MRI, how to perform cardiac MRI, or if you simply, want to advance your skills, just make sure you check the link Samuel is going to post. The first module will be released on the 1st of November. And we have a bunch of amazing speakers, I have to say, and I already partially seen most of the content. It looks amazing. So yeah, if you're interested about cardiac MRI, do not miss this. Will be a huge opportunity of sharing and to learning more.
Thank you, Julian. I just want to do an honorable mention to one of the people that I see on LinkedIn that is doing a lot for patient experience, and I think they don't get enough. It's Brendan, I think he's on the call. So he shows how we can just change a tiny thing on our day-to-day work to improve our patient care. So we developed this tool called Kypho Lift that you can use for patients with kyphosis, and you can actually scan them quite nicely without putting a lot of pads under their knees and things like that. So I'll also share that link so you guys can see it. It's not a sponsor. It's just something that I think it's very interesting to see, and I believe all of our attendees will also find it interesting. So I will ask now our guests, our speakers, to turn their cameras and mics on, and we'll start our roundtable. So I want to thank you all for being here once again. It was really enlightening to have all the presentations and to hear you talking about different ways of caring for our patients, how we can manage their anxieties, their fears on a day-to-day basis. So thank you all for that. I will start with one of the questions that popped up the most on the Q&A, and I think can involve all of you. It's more direct maybe to Sigrid, but I think all of us can jump in and say something, because it's about the future of radiographers. So a lot of people are afraid that we're going to be replaced by AI. A lot of people are also asking, what's the AI role actually within the patient experience? And also with the remote scanning, it was one of the last questions, I think, from Solange Pereira. She was asking if the future is for radiographers to perform MRI remotely, controlling more than one machine at a time. How can we ensure the patient care will not be affected? So Sigrid, I don't know if you can just start up the conversation. Yeah. All of you, please feel free to jump in.
Yeah, thank you for the questions. There are a lot of things to dig into there, I think, what you just said. First of all, I must say I've never worked in radiology myself, so I do not have the expertise of like being a technologist or the day-to-day life. But in general, and I think, first of all, I think when you look at where AI is being used in healthcare, radiology is where it's been used the most. And it's already being affected. Depending on which hospital you work in, you might probably notice that more or less. But being that, I don't think necessarily that jobs will be like you're going to lose your job, but it will be affected. I think it's not that AI will take over the world, will not take over healthcare, will not take over all of radiology, but more that jobs and tasks will shift, and not the jobs, if you get what I mean. And I also think for some extent that we'll see more patient care outside of the hospital. But please note as well that a lot of like the technology that's there, like I talked to someone recently, they were working on, I think it's like eye scan, scanner of the eye, like AI tools for the ophthalmology. And you cannot use a smartphone for that. Currently, who knows in the future? So you can't, like a patient can't do that. They have to go to the clinic. And that's the same for a lot of these tools in radiology as well, because they're so complex tools, you can't have these everywhere.
Absolutely. Julian, I think I have something to say.
Thank you so much, Sigrid. It was an amazing answer. And I want to open the discussion to the other speakers as well with a reflection. And first thing, I agree completely with what you say. I think probably the concern that came out from people watching at home this event regarding AI in general was about the fact someone was actually mentioned this. They were saying, yes, for sure, AI will have a massive impact, meaning that someone was bringing this example. I'm scanning like don't remember, it was a knee in 8 minutes. So they give me like a very short slot. And this obviously will have a lot of positives because we will reduce the backlog. More patients will be able to access an MRI scan. However, it might have drawbacks from both the radiographer side, but also the patient, because the radiographer might find himself scanning 25, 30 patients per day, whatever it is, but also the patient, the concern about rushing the patient experience. How can we preserve, ideally, the patient experience? You correctly said during the presentation that that should not be the aim of scanning as many patients as possible. But how can we actually make sure we preserve this?
Yeah, if I can continue.
Yeah, please.
So first of all, like preserving that, I think is also with implementing the AI tools. I mentioned a bit in the presentation as well, but we need to involve different key stakeholders. We can't only involve management because they will have, efficiency. They will have we need to earn money. There need to be other reasons as well to implement tools. You mentioned something in the beginning. What I just forgot my train of thought. I'll get back to it, but I see that Ruth also held up her hand.
Ruth, I think you want to say something. Please go ahead.
Yeah, I just thought I'd add a couple of thoughts, and I am not an expert in AI or MRI, so please take it all with a pinch of salt. But I am an independent observer, if you like, on patient experience, and through the Patient Experience Network, we've got a lot of insight. I think the challenge with AI is it is here, it is going to be here, and it's going to grow. So we can choose to ignore it or try to avoid it. But actually, I think we need to embrace it and find out ways to enable our patients to do that and to do that well. Then my second thought is the other known fact, and I'm back in my Death Valley here, it's tough out there. Efficiencies are with us. They are always going to be with us. And 8 minutes is in the future might be a luxury. Who knows? So I think the challenge is how do we make that a positive, and how do we therefore make every single part of our interaction count? And when we're with our patients, it's really maxing that out, walking with them, talking with them, setting them up as we're putting them on the bed, having that opportunity to really make literally every second count. So that I think we have to embrace these, because they're, whether we like it or not, they're going to happen. And so it's finding out a way we can really make it help us improve the experience, if you get what I mean. That's my penneth worth.
Thank you, Ruth. Selena, I think you next on the line, you wanted to say something, please do so.
Yes, thank you so much. Speaking from a technologist who still takes care of patients, I think moving forward with AI, administrators and directors and things like that, they need to ask the technologists, the people who do the day-to-day, everyday things. I mean, because we're going to help guide the AI, I feel. I think it's going to do, I think it'll enhance our jobs and make them easier. And that's my whole ethos and for the patient. So that's all I have to say about that. Just listen to the technologists moving forward when it comes to decisions in AI.
Thank you, Selena. Sigrid, I'll give you time, but let me just go to Jonathan. I think Jonathan has something to say as well. Please, Jonathan.
Yeah, sure. Thank you. I think obviously the idea of the efficiency, it's a genuine concern, and we look at a lot of the areas of radiography, we have quite short interactions. So we're quite used to dealing with quicker times, and it's quite scary to think MRI can become that quick. But CT has done that in my own lifetime. So we've gone from taking 30 minutes to a head scan to a breath hold for pretty much the entire body. So we've gone through this already in other areas. However, if there's going to be efficiencies in triaging, perhaps identifying patients that may be high anxiety patients, for example, it provides a lot of opportunity potentially to actually maybe improve our services in other kind of areas. So I think it's probably around the engagement of AI. A lot of the things, particularly currently around maybe diagnosis, improving things like noise, efficiencies in scans, but there's lots of other AI tools that can increase triaging and take away some of the admin roles we have, which can therefore potentially give us opportunity to increase person kind of contact and patient-centered care. So if we embrace it, yes, we're going to get more efficient with the scanning, but maybe we can get more efficient with not having to deal with junior doctors and other concerns and annoying things that bug us all the time, and maybe actually have more time for patient care as well.
Perfect, Jonathan. Thank you so much. Very insightful. Sigrid, I think you have something to say, and then I'll jump to Darren. I think you're off. Sorry, Sigrid. You're muted.
Thank you. My turn.
That today as well.
Yeah. No, I fully agree with Jonathan. Like really, letting AI being used for tasks that we don't really enjoy that much, and so we can focus on the patient care. So we can focus on a quality patient care. But I also want to mention one thing, and I don't know how it's going to evolve in Europe, but also in the US and Australia and across the globe. But in the EU, you have the EU AI Act now. And where it also says that for high-risk tools, which also involves AI for medical use, you have to have human in the loop for now, right? You have to have this combination that AI is not a lone-standing tool. It's to support the human. So it's going to enhance what you already can. So to help you work more efficient in some tasks, obviously. But the moment it does impact medical decisions, and treatments, you will have to have a human involved. And I think that's also very important for the trust of AI. So to have, we have this great tool, and it will be greater and greater the more we get it developed. But we have this possibility to use a tool that can really help us detect disease faster, be able to give treatments better. But in order to get that implemented in large scale, we have to have trust from patients, from personnel as well. Like everyone needs to trust this. And in order to do that, we need to as well make sure that we have everyone on board and have, again, the human in the loop.
Perfect, thank you. Darren, I'll go straight to you. Give me 1 second. There was one question that I think Ruth asked about this as well, which was the fact that, I don't know if it was you, Ruth, but there was mentioned the fact that, are we telling our patients that we're using AI or not? Should we tell our patients? Is this good patient care? Is this a good patient experience? So I want to hear from all of you guys. First, Darren, go ahead, tell us what you have to say, and then we can take this segue to move away from AI, because there's more things to talk about, which is, we can always go back to AI, of course, but Darren, please let us know your thoughts as well.
It'll be brief. Jonathan beat me to it. So I'm just going to pick up on that point around the focus at the moment is on image improvement and diagnosis for AI. But I think when we think about patient experience, there is a lot that could be done at the front end. I think we looked at our data. So for example, the research we did, we had a huge amount of data over a 2-year period. I think the more we can access that data, we can implement a patient-centered care using AI based on patients' background. So, Selena mentioned it in her presentation as well. We know certain populations, age group, there's other comorbidities, cardiac surgery has an impact, other bits and pieces as well. If we have all that data to our fingertips and we can then personalize our appointment slots, that's where I think AI could really come in and make a difference on patient experience. We do the same as an organization. Everybody fits into a 20-minute slot. There's no variation. That's why our staff have time pressures. That's why people may not give the care that they maybe want to give because they haven't got the time to do it. So we could use AI from that point of view. So those people who come in, and we've all had them, they will come in, don't talk to me, I'm happy to have a sleep for 10 minutes and just get on with the scan, that's fine. Whereas those people who need more time, we can give them the time ahead of it. And we can even give them other interventions such as a VR session or whatever to tailor it and really adapt and personalize their experience based on their background.
I fully agree, Darren. One of the things that people were mentioning on the Q&A is the fact that with AI, we basically scanning more patients and having less time to talk to the patients, which I think it's also one of the conundrums that we have when we're trying to implement AI. I know Ruth wants to say something, and then we'll jump to Julian, because Julian also wants to start some conversation. Ruth, do you want to go ahead? I think Jonathan was first. Jonathan, I think you had your hand first. I'm sorry. Jonathan, go ahead.
I was going to just say regarding both remote scanning and also the AI, absolutely, I think we should tell patients, and patients should be informed. So if we're using things, then they should be told. Obviously, we have to manage what that means for patients, though, when we tell them these things, because obviously they don't necessarily have the understanding of what's happening with that. So that's important to communicate the significance of these things too. But yeah, we could open a can of worms with the remote scanning in particular. That's a huge thing to consider around from a patient-centered care perspective. And I think, there was an interesting discussion from your last roundtable on this area, but obviously patient voice is really important to hear what they think about that.
Perfect. Thank you. Ruth.
Yeah, and just picking up on that, and also a comment that Selena made, I think if we can, and where we can, as we make the decisions and think about how we involve AI, or indeed do any change or process, we should be thinking about obviously our people's involvement in that. And I think Selena was saying we should talk to the technicians, but we absolutely should be talking to our patients as well. So we should be developing these solutions with the key stakeholders, which are our people and the people receiving the care, in my opinion.
Thank you. Again, just to close the topic, Sigrid and then Celine, and then we're moving on, please.
Thank you. So again, I agree. We should involve patients in the development, because they are the end user. Maybe not always directly, but they will be impacted by the AI. I don't know if we should I don't think we should ask for consent always when it comes to use of AI, but at least inform when possible, because I also understand it's not always possible to inform them. But also I want to highlight again the EU AI Act that also says that it's the rights of the citizen to complain about AI tools. So I can imagine that it might even become a part of the law that you have to inform patients when in use. And you should also be able to receive the explanation why decisions have been made. as a patient. So I can imagine, since that is written out in the EU AI Act, it's still not like you have to inform all patients, but I can imagine that will quickly happen.
Perfect. Thank you. Selena, please.
Yes, I just wanted to mention, Jonathan, thank you so much for mentioning advocating, prioritizing personalized care, because that's something I've been advocating for years. And the idea of AI, just gathering everything together for the technologist, for example, which arm should you use? Which vein is going to work for this IV? Things like that is beautiful. So that's all I want to say about that. Thank you.
Wonderful. Perfect. Julian, do you have any questions you want to use, or?
Yeah, there is one actually. There are two. I'll try to limit. Actually, one is for Jonathan, one is for Darren, but they are open to all the speakers. So to Jonathan, I have to say, I saw your slide about Tony Soprano being an MRI scanner, and let me say, I would like not to have Tony Soprano as a patient, just in case. However, if you have a patient like Tony Soprano, how would you deal with that? Let's say that, you know, in the UK, I will take the United Kingdom as an example. We have like the NHS, we have a private sector. So, you know, especially when you go in the private, patient might have like bigger expectation in terms of patient care sometimes. So how you deal in your personal experience, if you have any tips and tricks with patients that are a little bit more, let's say, grumpy, but let's say demanding, how do you preserve the right patient care in those cases?
Yeah, there's probably not a one size fits all, is there, with that particular approach? I think, and certainly from my own research stuff that I've been doing in this space, is that, and obviously, various speakers are talking about it. Obviously, how the person presents their demeanor, their emotions, and perhaps their, you know, maybe the aggression levels could be linked to anxiety, lots of other things as well in that kind of space. So I think it's up to be actually accepting that, you know, it's okay for a patient to be grumpy. I think we forget sometimes, and you were talking yourself, Julian, before, that you had some scans in MRI, but the context of having it as maybe a volunteer or for research is very different to being a patient. And obviously the reason they're having the scan is often there's a lot of their source of their anxiety and distress because of it's very emotive. And if I suddenly, well, I've had the scan recently that was for a cancer reason for MRI, and my experience in that was very different to my prior experiences. I've always fallen asleep in MRI because obviously the context is quite different. So I think really just creating that human connection with an individual, and we have to accept that patients are allowed to be grumpy, they're allowed to be angry, they're allowed to not be happy about the care. They're allowed to have all range of human emotions. Obviously, they can't be disrespectful or racist and things like that, but they're allowed to have a bad day. And that's okay. That's kind of normal. They're coming through healthcare. It's challenging. It's our responsibility to try and make that as human as possible. That will be my take on it.
Amazing, thank you. And I'll go ahead straight with the second question directly to Darren, which we can open actually to everyone. Darren, I want to know, thank you for your presentation. First thing was very nice. As a clinical lead, I want to ask you, how do you actually ensure, what are the tips you try to give for training to make sure that all the radiographers, the technology, keep the patient care consistent? Because I would assume maybe as someone act might be different from how the other MR user operates. So how do you ensure consistency in patient experience?
With difficulty, it's probably the simple answer. I think going back to Selena's point when she started her presentation, the big thing for us was about training. So that's where we've had a long-term relationship with Ruth and the Patient Experience Network in the training that we deliver, because I think when I came into the role, and I had the same from my training, the focus was very much around the technicalities of scanning, forgetting everything else. So one of the things we did early on when I took over in the role is we looked at introducing patient experience as fundamental at the beginning, but even not just that, it's the other skills around team working, communication, and that impacts on safety, patient experience, and everything else as well. So I think what we've tried to do, or what I've tried to do for the organisation, is have a holistic view. So the technicality competence is obviously needed, but actually it's the fundamental skills and the training which are really important. So that was one thing, but obviously what we have realised is obviously we can do that for trainees. They then go out into a department where they get disillusioned because what we've spoken them about in the ivory tower isn't what happens in clinical practice. And so we've had to try and inform that training more widely, where we have developed training packs that staff can try and engage with. But as I said at the beginning, the honest answer is it's difficult. We've got over 100 magnets nationally, so I can't be everywhere in all places. It's how we try and instill that, or try and get that shared ethos across the business and across the organisation. I think we've got some success. We've managed, with Ruth's help, we've got our own definition of patient experience from what the patients told us. So we use that. Obviously, we monitor very closely our complaints, and I have to say, we don't have loads of complaints necessarily in terms of numbers versus patients, but what I will say is it's very disappointing that over a third, or if not 2/3 of our complaints still relate to communication and patient and staff behaviour. But I think we can't say, or with our safety investigations, I don't think it's right to blame the individual and the staff member. They can have an off day, the same as a patient can. But I think what we need to start trying to do is look at the culture, and what are we setting up the patients and the staff to succeed or not. And I think there probably is an element where we don't, in the sense of time pressure. We've got to do more. Your priority is to get the task done, not necessarily look after the patient. And I think one of the, slightly side drift, but one of the really interesting or insightful comments that one of our patients said to us in one part of the research that we did is they actually said to somebody, "You just haven't got time for us anymore." And I think that's the interesting thing. Patients do come in, going back to your previous point about expectations, they do come in, they want to talk, particularly post-COVID. They may not have spoken to a healthcare professional at all until they come in for a scan. And so we were their main interaction, and they wanted to offload or have that conversation. But in most departments, we just don't have the time to do that. But there are little things you can do. And I think we try, the walk and the talk and all that kind of stuff as well. I'm going to shut up there because I'm rambling. So I'll let somebody else pick up. And hopefully Ruth can back up some of the stuff that we've done from a training point of view.
Thank you, Darren. I was just going to mention a few things. One of them is, I think Ruth was also talking about the experiences of the patients. And most of the times, that's the most important thing, how the patient experience the service that you're providing. I have a question for you, Darren. I don't know if you, in any of your research with your patients and the feedback or that you get from your patients. I worked for InHealth a few years back. And I know how it is to work in a mobile unit, for example, or relocatable, but we also have this within the normal hospital. And my question is, when you have a patient that is, let's say, a rugby player, or from my experience, people in higher levels of power outside of the hospital area, let's say I work in finance, or I'm a lawyer, and I'm used to have power. Those are the patients that most of the time I find to be claustrophobic. And I find to have the agoraphobia that Selena, and I can see she's nodding, Selena mentioned in her presentation. So probably you, Ruth, and Selena can jump in this conversation. But I sense that most of the patients that I have that suffer from claustrophobia and anxiety are men on positions of power. And as soon as I put them in the scanner, they feel they're losing their power. And for that reason, they most of the times panic. I think women deal way better with this pressure. But can I have your thoughts, the three of you? I don't know if you have any research or any experience on that.
I'll jump in quickly, and then I think Celine's probably got some good insights from a psychology, physiology point of view. And I think we've all had those patients, I have to say, and they are generally male, where they come on the scanner, they're rude, they're aggressive, they're very short. They then come out of the scanner and you think it's a different patient that's emerged from the scanner. So, we all have that. And I think it is a huge generalization, but they are, over the 24 years I've been in practice, I would observe exactly the same, Sam. I think it definitely, I think physiologically, again, I'll let Selena expand. Normally that's when they're having an amygdala hijack because of that anxiety and that physiological response that's causing it. How we respond to that can be challenging, particularly if we haven't got the confidence ourselves to be able to manage that and take that on board. I'll give a shameless plug as well while we're talking about it. One of the things that we found really useful is around trying to adapt and develop people's awareness of themselves and how other people are communicating. So one of the things we've done, and we haven't published it yet, but one of the tools we have started to use is something called Service Animals, which is a communication and a behavioural tool. So even just by understanding the tool, not necessarily doing a profile, because that's part of the element of it, it just gives you a very basic structure to understand where someone might be coming from. And if that's their view. That's how they prefer to be spoken to, for example, such as, I want to be short, just give me the information, I don't need all the fluffiness. Well, if you know that, then you know how to adapt your behaviour to respond to them accordingly. Likewise, we've all had the patients that come to us who want to know the ins and outs. How's the scanner working? What's the physics? What's all this? So again, you can tell that from certain behavioural cues or communication, and therefore adapt for them as well. So I think that's been a really useful tool in terms of how we manage that and how we can cope with those behavioural and communication differences.
Absolutely. I think it's very hard to train a radiographer in such a broad spectrum of cohort of patients that we can get. But let's hear from Selena, the expert in psychology.
Yes, you did an excellent job, by the way, Darren, of explaining it. So much so, I'm not going to go there. I'm not going to repeat it. So as my presentation said, people with higher economic status do, in fact, have higher anxiety. And the reason that is because they're used to having everything they need. So when things aren't, what they expect them to be or how it's usually, how they're usually treated, then that's when things, that's when they have an issue with it. So that's completely normal. I would like to, if it's okay, touch on the education aspect. Education aspect of MRI patient care. I've been advocating trying to have very specific education for patient care. Instead of it just being a tiny thing and safety, it needs to be a whole module in MRI patient or MRI training, excuse me. So I think that right there is going to help people become educated on there. And just on the idea of how to deal with patients, I do have a handout that I'm going to put on the chat that technologists and radiographers can use to help them deal with patients when they're anxious, to kind of calm them down at different levels. One other thing I wanted to, while I have the floor, is the time. I believe Sigrid talked about the time of patient care and patient care. I would like administrators to think about this, because there has been this avenue of, like you said, doing 8-minute scans or just going as fast as you can. The idea is if you give the patient more time, you're going to get more time, in the sense that no more repeats and things like this. Give them the time to acclimate to them. Give them the time to ask the questions, whether it be in the waiting room or someone else referring that, then that would be a really great way. So increasing time with the patient is going to increase your productivity.
I think, Selena, the main thing I think is the pressure from above. So we have our managers, we have our financials and CFOs, and just pressuring, we need more numbers. We paid for the AI on your scanner. Why are you not scanning more patients? Why are you still doing a knee in half an hour? So I think that's where the biggest problem comes in for us radiographers, because we want to give the best care we can to our patients, but at the same time, on the other side of the balance, we have someone, but we need the money. So I don't know how you see that, or if anyone in the room wants to jump in, how we manage that kind of situation.
I think if someone did a very, let's say 1 month trial of giving the patient more time or giving the exams more time, they would see that the completion rates would be higher because you gave them more time. I think if administrators would do that just to test it out to see if that works, then that would in and of itself would prove that giving the patients more time will give them more money, as opposed to the opposite.
Okay, thank you. Ruth, I think you next in line.
I was just going to pick up that time one, and then if I may, I'll just pick up from following on from Darren on some of the things he talked about. Time's really interesting because it's all about perceptions of time. And if you tell someone, and give people this feeling that we're really pressured, you've got to get on the bed like now and now get off. And that's quite different from don't worry, just take your time. You're still looking after the clock for them. As you said, Selena, there's more things you can do before and maybe more things you can do after. But I think
And I don't want to underestimate the impact of time on our people, our colleagues, because it's a huge pressure. But a lot will, I think, depend on how you're communicating that pressure to your patients. And if they're feeling the pressure, of course, that's going to cause them to be worried about staying still. But if they're feeling it's okay, I have time, and you're worrying about the time, I think that's quite different. So I don't want to dispute what Selena said at all. I suspect there might be quite an interesting study there, but I think a lot of it might be around attitude or the way that we're communicating time as well. But may I go back to culture, because Darren was talking about, you know, when we think of these trainees that have been trained and we send them back out into the world, and now they're this little drop in an ocean and they get consumed by the culture. And culture is interesting because there's this great saying that culture eats strategy for breakfast. And I think that is the real challenge. It takes years to change culture. And so what Darren's trying to do is do it through the trainees, but also through, you know, the incumbent team. And then you can start to make change. And I thought it was interesting when Jonathan was talking about the grumpy patient and we got into, you know, these patients who are difficult. I think the perfect storm is when you get your patient that's difficult and it's the 40th patient you've seen, and now your tolerance for that person has really reduced. And it's almost, well, how do you read your patient? How do you, because as Darren said, it's the tools that help us read our patients and then adapt to them. And if you've got and it's understanding why are they like that? And it is often around anxiety and control. So what can we do to give them a sense of control? Where can we give them choice? Where can we give them false choice? So, you know, I'm going to scan both sides, but would you like to do the left first or the right? You're now giving people choices that help them feel in control. And so again, I think it's around how you're reading your person, how you're adapting. And in that case, it may be around, well, this person who likes to be in control, so I'm going to give them choice. For another person, choice is just now, that's too much already. So I think it's really interesting, this idea of not all patients are equal. Grumpy patients, you know, they may be grumpy, but if you've given them choice, they might, as Darren said, they can transform, but they may then go, oh my gosh, they were fabulous. They just gave me, you know, the experience that I was after. So I'm going to shut up now.
No, thank you so much, Ruth. I think what you're mentioning about giving control back to the patients is one of the things that us radiographers do every day. When we give the buzzer to the patient, we always say, just remember, if you need it, you are in control. You can stop it anytime. So it's exactly what you're mentioning, giving control back.
That's another great control. Choice of music, control of side, you know, all of these things. Sometimes it's having the imagination to create false choice. Absolutely. So that so you're giving people options that, you know, frankly don't really matter in our world, but you're giving them choice.
Absolutely. Jonathan, please go ahead.
Yeah, and I think Ruth actually said a lot of things I was going to say. So to be fair, but I think the key thing around the kind of the emotion type things that, you know, if we're trying to, I guess, help manage the person's emotions and give them a positive experience as best as possible, even though, you know, there can be, you know, if you're a claustrophobic person and you have, I guess, experience panic and terror, it's not going to be a necessarily particularly pleasant experience, so we can't necessarily take that away from the person. But it doesn't necessarily take a huge amount of time. And I think to manage some of those, I guess, talking with the patient, I think I'm waffling now. I've come back. I had something clear in my head, and then because I was listening to Ruth, I've lost it.
The time I go through the same all the time as well. I want to say something and I get lost in the train of thought. Julian, I guess you want to jump in. Please do so.
Yeah, no, I just want to jump in thinking about the emotions because there was a question there that kind of like impressed me. I was like, oh, I'm not sure if I would like to ask this, but then I thought actually this is a very genuine, I think interesting question. It's very simple. There was one person that just commented and say, since we have a like very short span to try to relieve this anxiety from the patient, and sometimes like a quick action is needed. Is that okay to lie? Say, for instance, that a sequence is lasting like 2 minutes rather than 4. At the beginning, I was thinking, well, probably this sounds a little bit no sense, but thinking about it, when you're there, when you have a lot of patients, let's say a patient that squeezed the buzzer many, many times, and you say, okay, now it comes a little bit instinct, say, yeah, you have just 2 minutes left, or maybe a 4, 5, So what do you think about this? Is there a strategy to kind of reduce anxiety, or is just like a no way go compromise?
Please, Selena, go ahead.
Yes, one of the strategies that I use for that specifically is it's much easier to get through 2 minutes than it is 4 minutes, let's say. So so halfway between, because most of them have headsets on or they can hear you. So I just tell them when they're at the halfway point. So they're thinking about 2 minutes as opposed to 4 minutes in total. So you're just reducing the size, even though it's still the same amount of time. You take it in chunks, like in little chunks. That's how I manage it. And sometimes I do telltales when I have to get it done and it has to be done. I did have one patient call me out on it before, so be prepared for that if you decide, to do that. But most patients is okay with it, but in smaller chunks, even if it's continuous, it will help patients.
Selena, actually, I think it was Frank Shellock that once told me, if the patient will never know if you are the one scanning them. For example, for remote scanning, that was the example that he gave me. That we recently spoke about this on a podcast from Everything MRI, but basically he was saying that if a patient goes into the room, I'm taking the patient into the room, I position the patient and go back to my scanner. I don't tell the patient that I'm the one scanning him. It might be someone else. It might be a colleague that is with me. It might be a colleague that is remote. So I think it kind of balances this. It's basically the same thing. Are we telling the patients, for example, Sigrid, are we telling the patients that we're using a specific algorithm to do their reports later on? Is this something that we should do? Do you guys believe this is something that we need to tell our patients?
I feel the information, they have a right to know what's going on. And as Sigrid was saying, whether or not consent is necessary, the knowledge and the knowledge of what's going on, I think we owe that to the patients because it's their bodies.
Perfect. Thank you. Jonathan.
With the time queue stuff. Yeah, the time queue stuff is really critical. From my own PhD research, then a lot of people are talking about this, I guess, the mismatch between perceived and objective time and this dilation of time being a major contributor to their distress. And if they're unaware of how long they've got to maintain feeling breathless, if we're doing a breath hold sequence or being in pain, and the fact that they really want to complete the scan, and this this tension between experiencing distress and anxiety or pain or whatever it is that's discomfort. But if they know that they can only hold it for 2 more minutes, that actually that makes a huge comfort. So that constant communication and communicating that. Obviously, not naming any particular scan, we do have a scanner now that actually has a timer on there. Patients can see how long their procedures are. And I think actually having some visual cue or display would be a great benefit, because a lot of, well, 3 of my participants actually suggested that was actually we could have some kind of countdown clock or something to show how much longer do I have to hold and maintain this stillness and isolation before I get human contact. They said that would really be beneficial. So that's coming straight from the 3 patients that experience distress quite regularly as part of their experiences.
Perfect. Thank you, Jonathan. Darren, before going back to you, you were mentioning actually that we need to teach our radiographers and students maybe about this. And there's a message from Chloe. Don't forget what you're going to say. And she was saying, when I ask students why they've come into radiography as a profession, not one of them will say to scan people as fast as I can. So this is actually a nice message, because we all got into this profession to look after people, to care for others, not to make scanners faster. So I think it goes in tandem with what we were saying before. So just please go ahead and give us.
I think this perfectly summarized the state of this event.
Yes, absolutely. Thank you, Chloe.
There's 2 quick things. So one thing before I forget it is, I think that's interesting in terms of, I think we do need a huge cultural shift across the profession. It's not just MR. I think it's professionally, because there is that culture of task focus, get them through, get them done, get them onto the next. There's not enough scanners, backlogs, whatever. So I think for that, unfortunately, there probably has been some research done there. If not, somebody could do it. I think it'd be very interesting to see when a trainee comes in as a student, is that compassion almost beaten out of them as they come into the culture of a radiography department and what happens. So I think that's something we need to look at professionally, I think. going back to what I was going to say to do with time, is another thing that comes in with that, and I think it might have been Chloe that messaged on the Q&A as well. One of my personal biggest bugbears is people not talking to patients over the intercom. And I think that ties in with the time in the sense that people can literally be in there for 25, 30 minutes and not hear a soul. And I get various excuses as to why they don't do this. I have to say Siemens, by design, don't encourage people to be spoken to unless you're going to put a little workman up or you pause it. But I think that's the biggest thing. And I've done a piece of research with one of our NHS trusts at the moment, where we're using the auto voice from Philips, where it automatically gives that time in for the patient. And actually, the preliminary results are suggesting that even an auto voice from a computer is better than nothing, which comes right back to being informed. So, we are getting quicker scanners, totally. I'm not saying that every minute we need to say to a patient and we need to adapt it. Obviously, I'm ancient, so when I first scanned, we had 5-minute scans on average. So we did speak to the patient after every single one. But I think we should be doing, for most patients, at least talking to them twice. But I think if you are doing 6 scans, but it lasts 15 minutes, we'll at least speak to them after the first 2 or 3, or even check in with the patient. Do you want me to speak to you? How are you doing, or whatever? But I think that's the biggest thing. And again, it's another piece of research we're doing at the moment, looking at complaints, and it comes out from the complaints from patients. No one spoke to me. I felt I was left alone. I didn't know what was happening, and all that kind of stuff. So I think the time is one thing. We've all lied. We've all stretched the truth a little bit. But actually, I think it comes back to that regular communication over the intercom between the scans.
And I think, Darren, this goes for any patient, not just a claustrophobic patient.
No, this is everybody. Yeah, I mean, you adapt to the individual. I've had patients come in. I've just finished a night shift. I'm just going to sleep for 20 minutes. Don't talk to me. Absolutely fine. That's the individual. But I think even for a standard non-phobic, anxious patient, I think letting them know that I'm here. I'm going to do your scan. I can see you. I can hear you. If you need me, squeeze the buzzer. Even if that's all you say, and then you say the last scan's coming up now, they know somebody's there. Even the remote scanner thing might change that, but
We'll see. Do you think that, Darren, just to finish, do you think like real-time translations with AI, as Sigrid was mentioning, the approach that we have with patients, as it will be also different? Real-time translations would be something that will help this factor as well?
Yeah, no, definitely. And again, I think with the auto voice that we've been trialing, there is the scope to change that as well, and adapt that to translate as you need to as well. But regardless, it all comes down to being informed and having that contact at some point during the scan.
Absolutely. Goes all back to what Ruth was saying about expectations and patient experience, for sure. Selena, I think you want to jump in, please.
Actually, I think Darren has said everything I wanted to say. So, yeah, I think talking to the patients, you would not imagine how many patients say they were left alone for 30 minutes. So all the radiographers and technologists, talk to your patients, please.
We just have a comment actually from Shermarva, and saying, I typically ask how my patients, sorry, he just jumped, how my patients like communication throughout the scanner as one of my preliminary questions. Some of my patients sleep, some like more information, just what Darren was saying as well. So I think we all should do this and adapt our practice to the patient we have in front of us. Jonathan, please.
I'm going to say isolation and loneliness is a very common theme that came through from all my participants, and particularly that were distressed. So I think for distressed patients in particular, I wholeheartedly 100% agree with Darren saying there around the communication. That will definitely help those particularly anxious patients that may terminate early or just have a bad experience.
Wonderful. Thank you. Julian.
Super quick feedback on what Darren was saying. Coming from a working in a background where we have different scanners, and one has that kind of auto voice that you mentioned that will update you after each sequence about the time that it's going to take, plus the ambience room experience with different colors, the spa music, and the other one is a standard MR scanner with nanotace. My perception is when I see patients coming out, you can see they had a different experience. Without any, qualitative data, just simple perception, you can see they come out and they say, yeah, that was pretty easy, more easier than I expect, yeah, or good. While other times you can see, oh, that was quite challenging, well, that was long. So I think, yeah, small things, but this have definitely an impact. I completely agree with you.
Thank you, Julian. I agree with you 100%. I think having both things is the ideal world. Have a great entertainment system or beautiful room and then excellent patient care. I agree with you. Sigrid, we have a question as well. I think it was from Patricia, and she was saying personalized care will bring us sometimes extra costs. And how far in the future are we in terms of using AI for personalized care? I think it comes from one of your slides that you had there.
I don't think we're there yet. We're not there yet. Regarding increased costs, to some extent, yes. If you start, like I had this discussion before, because if you start taking like genetic tests and sequences of all the patients, obviously that's going to cost more money than the standard treatment. But if that can detect a better treatment that will be faster, the patient will be less in the hospital with quicker recovery. Will it really be that much more expensive? It needs to be done research on it. But I think actually when we start seeing much more personalized treatment and care, we'll be able to see much like a shift in where we spend the money.
So I agree with you. I think we're not there yet, as you mentioned, because all these AI algorithms, if you look at it, they are extremely expensive. And most of the hospitals don't go for it straight away because they don't see it. It's the same thing with safety. It's not profitable to the naked eye. So because they're not getting that revenue, that stream revenue straight away from using these tools, they probably put it on a shelf and try to do what they always have been doing. And that's something me and Julian fight quite a lot against that. I've always done this way because we want to bring new things to our community and make people evolve. It's not that we're replacing ourselves or we're replacing our workflows. We're trying to work in tandem with these new technologies to make our patients' lives easier, and at the end of the day, our own lives easier as well. So I agree with you, and I think it will take a little bit longer.
Just a comment to that, if I may.
Yes.
Also about the personalized treatments, for many of them, especially if it's a new treatment, you need to have research on that to say that it's better for that specific patient group. So you can't just do personalized treatment. It has to be based on something, and we're not there yet. To some extent, for some, like if you give like one-to-one nutritional treatment and advice, yes, that's personalized treatment. But it's still general for the whole population.
Absolutely.
And we need to have that data.
There was another question, I think it was from Zafar, and he asked, what will be the role of AI for differential diagnosis? Because nowadays we're using lab tests. For example, you do an MRI scan, the patient went through all of this to have a diagnosis, and then it comes out and it's inconclusive. They do labs tests. What's the role of AI in this? Can AI reduce this need, or do you believe there's something that is going to change this pathway in the future for the differential diagnosis?
Honestly, I hope and I believe that the whole pathways of patients will change, and that we will see different, like the processes we have currently will change. What we also discussed about like how much time you use for a scan and how to like tell the patients how much time you use on that patient. Maybe we're not maybe the whole process will change. And the same with the diagnosis as well. And thinking about all the data you can combine for something, maybe we're able to set the diagnosis without some of the tests that we're currently doing. But that really depends on the type of diagnosis you would be able to have. But even if you can use AI to improve the tests that you have done, for example, the MRI, I saw one of the questions as well. So how can you improve the quality of the image? Well, by reducing noise, increasing the quality of the of that image, or so you can actually see things that you're not able to see with a bad scan, but now the scan is usable.
Perfect. Thank you. I don't know if any of the panelists wants to jump in. If not, I have a question for all of you. So one of the questions that we had is how can we adapt the way we work to cater for patients with ASD, ADHD, neurodiversity? Is there any techniques? Maybe Selena can talk about this, or Darren as well, or Ruth, I don't know, any of you. How can we approach these patients better? How can we cater better to their care? Because these patients are challenging for us as well as radiographers if we don't have the proper training. So where can we find techniques to help us dealing with these patients on a day-to-day basis? Darren, please.
George, jump in. I mean, it's an interesting point. Obviously, there's a lot of research done from the team at City around particularly MRI with autism. Some of it, though, what I will say is some of those techniques are no different to whatever we want to label patients with. And I think a patient, regardless of whatever else, neurodiversity, whatever it is, they're still an individual and they still need to be adapted for and treated as an individual and all those kind of things. So I think a lot of what we do for all patients is applicable. Obviously, there are extra things, hyperacuity, photophobia, other sensitivities potentially to deal with as well. But I also think it then comes back to, do we know that in the first place? So going back to my comment before about AI, if we know there are patients with extra requirements for whatever reason, if we know that beforehand, we can then adjust for it and manage it. And I think a lot of the time it is time. Again, we keep coming back to time. There's never enough of it. But if we know that, and obviously, we can't rely on the old school paper forms. They never tell us what patients have got until they turn up. Even from a safety point of view, that's not reliable enough. But as we're now getting this big data, and we can share databases and bits and pieces, and we can know that in advance, we can give them the more time to do what they need to be doing. So I think really the short answer is, if we have more time, it's using the techniques that we already have to adjust and adapt to that individual and keep them informed and do whatever they need as an individual, regardless of whatever we want to use labeling wise for them.
Thank you, Darren. The reason why I asked this is because it was one of the questions, but also because on NHS, for example, we have dementia champions. We also have dementia champions on our private hospitals, but we don't have autistic or neurodiverse or ADHD champion. So that's why I was asking you if the practice should change. And I agree with you that each individual should be treated as unique, and we should cater for their needs on the spot if possible, or beforehand if we know the information beforehand.
Yeah, and on that point, Sam, before Ruth jumps in, I think it does need to change on that general point. Obviously, we've probably all done, particularly in the UK, the Oliver McGowan training and other bits and pieces that have come out recently. And I think there is a need for it. And I think it also comes back to undergraduate education in the first place. So, is it coming into undergraduate training, that increased awareness, but then also recapturing that for people like myself? It's been a long time since I did my training, so how do we keep people up to date at the same time as well? Which is why I think research from like Christina's research from City, etc., has been so important, because it gets it onto the agenda. But I agree. I think we need to be thinking about how we do that and how we manage that properly, and not just focus on other little groups. That's the only risk, is you have a champion for this, champion for that, but actually, let's just champion patient experience, full stop, regardless of whatever we want to, whatever the patient's coming with the history.
Sounds great to me. Absolutely. Ruth, please.
I think Selena might have been before me, but
sorry, Selena.
Now I've got the microphone, I'll go for it. I'm not shy. So I think it's such an interesting question, because we consider this to be kind of like a minority, but 25%, 1 in 4 people will have a disability, and that's going to be understated because that's a kind of a known disability. And we've got all of the hidden disabilities. So Darren's point about we need to almost be ready to manage the person that's in front of us and adapt our start, read what we're and then adapt and do the best we can, I think is probably the best guidance you can have, and have some tools that have enabled you in training and I guess awareness to understand a little bit about what might work. But it's normal. It's every day. It's just perhaps we don't always realize the hidden disabilities we've got in front of us, let alone learning disabilities and all of, we talked health literacy earlier on and digital literacy and all of these things. So I'm not sure that's actually helping, but I think we always think that we always talk as if this is rare. It's not. It's actually very, very common.
And most of the times we don't even know about it, and the patients might not be comfortable to share with us.
Exactly. And sometimes don't even know themselves.
Absolutely.
Particularly with learning disabilities, many people don't know.
Or even
and does it matter? It's not the right phrase, but therefore we simply have to work with who we have and do our best to engage and give them a great experience.
Absolutely. I agree 100%, Ruth. Thank you for your input. Selena, please. Sorry, I overstepped and I didn't notice you were first. I think your mic is off. Sorry for that.
Yes, there you go. No worries. I actually did that intentionally, so it wasn't you. I had someone at my door. So I wanted to just mention some resources that people can go to in order to be able to for information to help people with disabilities. There's one, we're talking about autistic patients. There's a organization called Autism Speaks. That's a really great resource. There's also a resource of ADA. It gives providers, healthcare providers, information that they need of how to deal with patients with responsibilities or deal with patients that have these disabilities, excuse me. Yeah, there's a lot of them. I can give you a list of them that you can share, Sam, with everyone.
Yes.
And so, perfect.
No problem.
That's all I had to say.
Thank you.
Thank you.
Jonathan, please go ahead. And then I think we'll start doing the closing remarks, but please, Jonathan.
Yeah, I have two siblings that are neurodiverse, and so I have personal familial kind of experience in this space. I'm not going to say there's any expertise in managing that in an MRI setting because, as I think, as Darren pointed, there's some fantastic research coming out of the city, and obviously it's probably a service-wide cultural thing. Actually, just looking at the person-centered care, but actually, I think we also got to be very careful that actually there's a huge amount of diversity. Again, so two people that are autistic, they have exception, they're individual. One person might have a light sensitivity, the other person's not bothered. To me at all. So it comes back down to talking to the individual. I think it's that individualized care. That's the whole point of person-centered care, is about the individual. So we have to take that time. We spend a lot of time working through, I guess, looking at patient safety. And that's a huge part of our role at MRI. And yeah, we should put patient-centered care at the same level of concern at the front end and center of our in meeting with patients.
Wonderful. Thank you so much, Jonathan. Julie, do you have anything you want to add or any other questions, or should we jump into
No, if not, just thank all the speakers. I think each contribution was great, and I think it added further value to the final discussion. So I know they also took valuable time to share all these insights with everyone. So up to you for the final remarks. It's a little bit sad to close this. I mean, I was actually enjoying it, but yes, please go ahead. I think everyone is.
You can go a little bit further, a little bit longer if people want to. Yeah, so basically, I just want to mention one thing. It's a brand new company, and I think I have to mention them, even if they're not public yet. But it's about patient experience as well, and radiographers' experience. So it's called SNS System Designs. It's done by Seeds and Sherry, and basically they're developing this alarm there. You can it's for a radiographer alarm, so it's imaging tech alarm system. It's called ITAS. So imagine you have a patient in stress and you are the only radiographer within the department with that patient that is in distress. You can basically call for help. So it's something to keep an eye for. At the closing remarks from our side, I just want to say thank you very much to Jonathan, Ruth, Sigrid, Darren, Selena. You guys have been amazing. It's awesome that you're here to give back to our community. And I truly appreciate you guys for being here. Jonathan, I can see the sunrise.
Yeah, I can say, can we shut out one moment to him? I think he's trying to.
I think you need a special mention because you spent the whole night with us. And of course, to our attendees, all of them, I really want to thank each and every one of you that came today and support us on a daily basis. I saw a lot of recognizable names for me and Julian. So thank you so much for exploring this world of MRI with us on a day-to-day basis. And of course, to our main sponsor, PDC, they've been a huge help for us to do what we do. They are a huge entertainment and MRI company in terms of entertainment systems and setup of MRI environments. You should check them out. So I'll go through you guys to tell me your final remarks. Well, if you have anything to say to our attendees and to ourselves. So from me, it's a good night and thank you so much. We'll start with Selena. We'll go to Jonathan, Sigrid, Ruth, and Darren. Thank you very much. Selena, please.
Yeah. Yes, again, I would love to thank you, Sam and Julian, for creating this platform. It's what the MRI environment needed, all the specialists in one place. So that is wonderful. Thank you so much. The only other thing I want to mention is a nice plug-in for my consultancy and my brand new book that is just out on my website right now. That is for people for curriculums and things like that. Yeah, and my mini MRI consultancies that I'm here to help any technologist with any question, because I realize in our field, it's a little tight, I guess you can say. People don't share information, which is why this is a wonderful, wonderful platform. And I will be there for you to help you through whatever it is you need help with that your coworkers may or may not want to help you with or can't. I'm there for you. So thank you again. And I just want everybody to be well and choose happy.
Thanks, Selena. Jonathan,
you.
please.
Yeah, thank you. Thanks for the speakers, and obviously to both of you as well, just for the opportunity. I think just probably my biggest thing is that, a small thing can make a difference, and culture starts with change in probably one person and can be infectious. So, you might feel a bit disenfranchised and might work in a very busy place, but actually, for each of your patients, you can make a very small difference with, a small band of interaction. So do be that kind of change. And I guess, the culture needs to change. You can have an impact. So use your sphere of influence.
Thank you so much, Jonathan. Wise words. Sigrid, please.
Thank you. So again, thank you for organizing this, Sam and Julian. And also, a happy birthday to Jonathan's son, because it was birthday today, no?
Yeah.
No, I just want to say that no matter what, like if it's AI or something else, it's really about putting the patient in the center. And I think we need to remember that with or without new technology, no matter where we are in the world, but keeping the patient in the center, keeping the patient welfare in the center, and that's how we can be able to develop good tech tools, but also provide good treatment. And then for anyone who wants to go dig more into AI in healthcare, not specifically radiology, but in general, feel free to connect with me on LinkedIn and search me up.
Thank you, Sigrid. Appreciate it. Ruth, please.
I would like to echo the thanks. It's been fabulous, and thank you for the interaction on the chat. It's been great to see. I'm going to echo what Jonathan said. I think it can feel a little bit like Death Valley right now. It's tough wherever you are. But we can create our own super bloom, and it's really working out what you can do. I think it can be quite easy to focus on what you can't do. But what is in your control, what is the art of the possible? And often, as Jonathan said, it's the small things that can make a really big difference, particularly in patient experience. Yes, it'd be fabulous if we all had, wonderful new units with all of these state-of-the-art lighting and sound, but actually, sometimes you will be the bit that makes the biggest difference. And I'm going to have my own plug. We are the Patient Experience Network. Please do feel free to sign up. We don't have a good enough representation from MRI. We know there's some brilliant practice out there, and we put the spotlight on good practice, and we try and help organizations improve. So we'd love to share your great work.
Thank you so much, Ruth. I've been a jury for the Patient Experience Network, and I can attest it's a great thing to do. And thank you so much for that opportunity as well. Darren, please.
Thanks, guys. And thanks again for the invitation to be part of the event. I feel like the pressure's on for me to leave with some amazing statement. I guess the key thing for me is the relational aspect of emotional experience is the key takeaway for everybody to think about. And it is a bit cliche, and I know Ruth's used the quote already, but I love the quote. I think it is linking back to that Maya Angelou quote around people won't remember what you've said or done, but they remember how you've made them feel. And I think that's the important thing to take away. We are emotional beings at the end of the day, and people want a timely, informed and a personal experience, and that can make all the difference. So whether it's the first patient or the 40th of the day, it's trying the best you can to keep that in the forefront of your mind so that we're making a difference for those individual patients as the day goes on.
Thank you so much, Darren. Julian, do you have any last words?
Yeah, I mean, let me just add some thinking about it. We don't have yet a dedicated session to our podcast about the patient experience. So it would be nice to invite each one of these amazing speakers. We might probably need to coordinate some travel from the US to Australia. It might be a little bit hectic, but we will do our best. So thank you again, everyone. It was really a pleasure to have you here.
Absolutely. Thank you all so much. And we hope to see you on our safety event in November 19. Have a good day.
See you.
Bye-bye.
Thank you so much. Thank you, everyone. Bye-bye.